Oh. Would it be best then?
Can I go? Bore da chi gyd, a croeso i'r Bwrdd Iechyd Prifysgol yn Ironbarn. Welcome to our board meeting today. And welcome to our guests from PALS who are here and those who are observing on live stream. Today's meeting will be available for viewing via our Health Board website after the meeting, if anybody would wish to see it further. Do we have any apologies for absence? No. Are there any declarations of input from anybody around the table on any issues in the open agenda for today? No? Just a slight change to the agenda. If you don't mind, I would like to, after the chair and then the chief executive update, move Tracy's public health report up to the next slot after that, so that she can go and do her thing, which is very important, and every good luck. Thanks to everybody. It's thank you. Okay. Can I ask if any member wishes to bring forward any item from the consent agenda for individual discussion, or are we content to have those under consent? Yeah, thank you. Update from me. Right. Oh dear, it seems to be ever so busy. Apart from my bilateral meetings and my visits, I've had a really good set of visits to our discharge wards in county and RGH to see the work that's ongoing in better combining the community social care and hospital services for a community, and really they really are working very, very well and hard together. I had a meeting with the chairs and the chief executives of Cwmtaf and Cardiff with the Cabinet Secretary about the South Wales Centre of Excellence, which is on the agenda today, and so we'll have further update on that. I also attended a small seminar that was provided by the Monmouthshire Integrated Care Team, which, as you know, has been in existence for some time, between health and social care in Monmouthshire, on the North Monmouthshire Improvement Scheme. So the scheme that has been operating now for, I think, probably 2.5 years in the south of the county is being proposed to extend to the north of the county. Now it has been evaluated in the south and has proven to be so successful. The county councillors were invited to attend, and they did so. Penny was there, along with a number of other councillors and the leader. And I thought that the staff did a really excellent job, including Brian, the NCN lead for North Monmouthshire, in really extolling the virtues of the model, what we were able to achieve in the south, and how we wanted to extend it to the north, and how that fitted in with the redevelopment proposals for Dixon surgery, etc. It was really well received, and I was very pleased to see healthcare assistants providing evidence on the sort of work that they were now doing in the community to show how they've extended their roles to the benefit of the population. So I was really, really pleased with that, and I think it went down very well with the people who were there. So thank you very much to that team for their enthusiasm and their really hard work over the past few years to enable this to happen. So that was good. I've had a couple of RPB leadership meetings. That's with the other RPB chairs and the chief officers, basically, is what they are, about a number of issues, and we were all quite keen that there should be much more openness in the evaluation of and the describing of unique schemes within each area, so that we could learn from each other about what worked, because we all have the same problems. We have different populations, but we do have the same problems. what really worked, what was value for money, what did the individuals within communities believe they were gaining from these innovative schemes, so that we could stop reinventing the wheel and actually work together much more closely. We also talked about the Care Action Committee meeting that had taken place, which well, it was an area by area review of how we were getting on with the 50-day challenge, from which came the idea that we really needed to start to move the agenda forward, to look at what was the greatest cost-effective methodology that we could implement to improve conditions within our communities. The chair of Swansea Bay, representing the NHS chairs, and I, representing the RPB chair, met then with officials from Welsh Government to describe how we would like to suggest to ministers that we could move the agenda forward. And we will wait and see from the next agenda, which is due today, whether or not we've been able to have any influence. We've had a cooperative meeting, I think you could call it, between Cwm Taf, ourselves, and Cardiff and the Vale about future planning that we are undertaking together, and we'll come back to that further later in the agenda. I also, for the Health Board chairs, attended the Culture, Leadership and Succession Board run by Health Education and Improvement Wales, looking at the Aspiring Chief Executive Programme and the outputs from that so far, and the issues of mentorship and coaching for our managers for the future, because we really do need to develop that much faster and much further than we've been able to at the moment. The chair peer group had met twice. We have also had a number of meetings looking at designing the services for the future with chief executives and other senior staff in health boards. The chairs are keen to cooperate and produce a strategic intent for the next 10 years to outline how we believe, given evidence, the services should progress in order to meet the changing needs of our populations. So that work is ongoing, and we're in close contact with the chief executives about it. I had to give a little speech on behalf of chairs. I don't know why I was chosen, but I thought I got the short straw really, on the induction for new board members, about what it's like to be a board member. And I'm afraid Neil was on the call, so I thought, I hope I behaved myself. But it was quite good. It was very good that at last executives were part of that training programme as well, because, you know, they'd always been excluded before, which I thought was really very good. So they were there. So apparently that went down all right. And finally, we've been conducting a number of searches, employment searches for new independent members, because sadly we're due to lose 2 members. I feel as if you're deserting us. But we've had quite a good response for the third sector, and we're also sifting for the trades union member, but I can't tell you how much we're going to miss Louise. Nobody can replace her, actually. Like, you've been so unique and valuable. So that's basically what I've been running around doing. And are there any questions? No? Good. Good.
Yeah, thanks, Chair. So, yeah, it's been as you said, an intense period. We've kind of moved forward into spring, but whilst we've seen a reduction in those respiratory illnesses and, you know, urgent emergency care systems still under pressure, but less so, we've still seen some kind of peaks in demand, particularly on stroke, cardiology, over short periods of time, which has continued to put the system under a lot of pressure, and a high acuity still coming through our teams with the, times when our recess and our intensive care units are full, which is quite unusual. So we continue to monitor that carefully. And it's such a busy period because we're not only trying to make sure we, can land the end of the year, but also plan for the years coming. So it's been a huge ask on our operational teams. And particularly the amount of focus on waiting times and that, trying to eliminate 104-week waits has been pretty relentless. And we're on the final few days now of trying to eliminate as many of those as possible. And we'll have an update later through the performance report. It's probably worth noting there was the escalation update, so the Welsh Government escalation intervention arrangements were formally announced and our health board position has remained unchanged. But we're having really constructive discussions with Welsh Government around the progress we're making towards a situation of de-escalation. So we'll obviously pick up some of that through the agenda. I wanted to draw out the situation around Dr. Ahmed and Dr. Allenson that we had a detailed discussion on at the last board meeting. And obviously since the board meeting where we'd had the Bryn Mawr partnership handed back to the health board, 4 other partnerships were handed back and the primary care team have been working hard with. 3 were handed over to us on the 1st of March and 2 more planned for the 1st of April. And that leaves 3 remaining partnerships with the health board, with the GPs, and they continue to be in enhanced monitoring, and we monitor that situation carefully with a particular focus on Pontypool, where I've been meeting with some of the local MS and MPs and some of the concerns that are coming through that. So we've got a key kind of focus on there. It's really important there's a smooth transition for those 5 practices. We normally do that in 6 months. We've done it over a shorter period of time to ensure there's no impact on service and again support the staff who obviously have to then transfer contracts, etc. Since we met as well, I know Leanne and Lloyd from Primary Care met with ABB. There was a public meeting there, very well attended. And again, we've committed to setting up patient participation panels. And we're also in the process of finalising a detailed communication and engagement plan with not just MPMSs, counsellors and patient participation panels, so that there's a kind of real kind of structured way of communicating and involving the public in our kind of plans going forward and working with us in terms of how we try to improve the challenges of primary care in those areas. On the back of that, we had a really useful session as an executive team with a big focus on the prevention agenda, primary care sustainability and our kind of place-based care planning and the development of really trying to focus on place, with Blaenau Gwent being a key area of focus for us. And, we're really keen that this year's plan, the one coming, has got a much greater emphasis on this part of our work going forward. I know Tracy's public health report again reinforces the importance of that agenda. The chair's mentioned the All Wales workshops that we've had as chief execs looking forward, so I'm not going to repeat that. And as you've also mentioned, we've been continuing to develop our regional planning agenda. We've got Manchester Health Park on the agenda later, but huge amounts of work going on, both in terms of delivering the cataract plan to also developing a programme of work around cancer as well. So really are trying to make sure we're working together on the areas that are most relevant. There were 2 conferences held in the last few weeks. I know Leanne and her teams led a cancer conference. It was really well attended and really well received by the teams, really kind of a deep dive on work that we're trying to do to improve our cancer pathway and experience for patients. And I know that was, again, is a key priority focus for us and continues to be as we go into the new year. And there was also the first Women's Network Conference that was held, which I know was really well attended. It was hosted the day before International Women's Day, and it was a great success for those who attended. So as we move into 25-26 from next Tuesday, as I know, there's a huge amount of work being going on around putting together the IMTP, and that's on the agenda later, and a huge kind of effort and ambition by the teams to continue to improve and potentially deliver a balanced financial plan, but we pick that up later in the agenda. That's it. Thank you, Chair.
Thank you. Any questions to Nicola? Many of those issues will be written with you today. Thank you. Could we have Tracy's public health report.
Thank you. Yeah. And thanks everyone. Hopefully you've all had a chance to see this year's Director of Public Health Annual Report. You'll remember last year we had a focus on babies, children and young people. This year the bus has moved, showing a bit more of a life course approach to public health and looking at preventable premature deaths. And we know within this space the greatest cause of premature death is linked to cardiovascular disease, diabetes and cancers. And what we're trying to do now is look at the causes of those things. And we know the biggest drivers for premature mortality and indeed morbidity is healthy weight and also smoking. But it's too easy to settle on those things. So we're now starting as a team to think about the causes of the causes and move into that wider determinant space and understand that whilst we have conversations a lot around health inequalities, as health isn't distributed equally, neither is choice. So I'm starting to ban, it's causing great consternation in the team because I'm banning them from using terms like behaviour change and lifestyle choices, because neither of those things are freely given to our communities. So that's quite hard in public health, they'll bring in every sentence on every policy. So they're going, what does it say in terms instead of behaviours? Well, I don't know, let's get creative and do something. Because what I want us to do in terms of the way we start and approach public health is really to understand the causes of the causes and understand that choice isn't active. We do, particularly in the space where we talk about obesity, we fat shame children and blame parents, and we think about calories in and energy out. We don't consider the fact that families will have to buy food from the shop closest to them because we don't all have the luxury of cars. We don't think about trauma. We don't think about the environment in terms of the way we live and the access to the freedoms of choice. And equally, when we look at things like smoking and people think of that as a lifestyle choice, there's no freedom in addiction and neither is there any choice in addiction. So we're starting to change the conversation. And that's what this year's DPH annual report does. We are aligning this alongside a whole series of community conversations. One that we've got live at the moment is the Great Weight Debate. So we are out talking to our communities about what does weight mean to you, trying to do away with the judgment and shame that exists around healthy weight and start and change the conversation around that. We know at the point where people feel judgment and shame, they close off to information. So we just want to change the way we do good public health practice within our communities. This report will inform our public health framework, and our public health framework will be our delivery agenda to make sure we're delivering our obligations and ambitions that are set out in the IMTP, working very closely with all of our local authorities to make sure that we're delivering at a community intervention level and really starting to put public health at the heart of good practice within our communities and making sure that we start there. And that isn't about dissolving our responsibility to the communities for them to solve all of their problems themselves, but we absolutely have to use the strength and knowledge that exists in our communities to actually generate good public health practice and improve the health outcomes of our populations, and move the conversation from a conversation around inequality to one of equity and social justice. So this is the start line of that really, so that we can start and change the story of our populations and start and improve the health over the entire life course over the next 10 years and outside our plan.
Thank you. Thank you. Are there any questions to Tracy? Ellen.
Excellent report and really informative. I just wondered, how do you get the report out to the general population? Because there's lots of useful information there aimed at the public, but how is it distributed, or how's the message?
So we have the joy of Scott in the team, who's our strategic comms lead. So we are busy pushing this through all of our community groups at the moment. It's gone out to all the strategic partnerships with the request that it gets disseminated. There is a bit of a tour going on at the moment where we're talking to community groups. I started talking to Director of Education as well, so we can get it into schools. We know the best way to educate parents is through their children. So starting there is really key, but there are mechanisms. We found with last year's that certain pockets of our communities were missed off. So we have adapted our strategy to hope that we do have that further reach, because they are written, and usually DPH annual reports remain quite academic and they stay in quite a strategic space. I'm keen that they're not. There should be a tool for our communities, and they're written for it with that in mind. But there's no point doing that if we then don't get it out to our communities. So we have hopefully teed that off a little bit better this year. Thanks.
Thanks very much. Thank you.
Thank you.
Paul?
Can I agree with Helen about the excellent report? I just wondered about the working with local authorities and the sort of the voluntary sector, and because obviously working together can make a sort of big difference, and in particular what creative and innovative opportunity there might be, particularly, for example, in primary care. And we've got the situation we've had with the e-Harley and in those particular sort of areas where there's now an opportunity to review and refresh. And I just wondered, are we tying in with that as well, looking at preventing part of that? Because then that would probably be very well supported by the local councillors and the members of the community.
Yeah, 100%. Paul. So Nicola referred to it in her opening address around the work that we're doing around place-based care, and that is predominantly being developed within that primary care space. We're working really closely with primary care from a public health perspective to build what we're calling, as a working title at the moment, a community model around that. So where we can actually get good health information and wellbeing information before people need to access primary care. So actually getting that work done in the communities, working really closely with the local authorities. And I had a conversation with the leader of Monmouthshire Council last week as well, because of some of the work that we're doing in Torvine and Glenargwent at the moment, and how we can bring Monmouthshire into that conversation. There's already really good practice across Monmouthshire, and also within Newport, there's a huge amount of work going on there in terms of pathfinders, both around homelessness and also domestic abuse. So really thinking about how we can do that, and then using our strategic partnership landscape to think about how we can do that at scale, and then take it back into the communities to work around those community assets to drive change at that level. So there are processes underway. It is a work in progress. We're not complete yet, but I think we do have a blueprint to actually start and drive forward at pace.
And also to applaud the work within schools, because I think there's a real opportunity to engage with young people about what they want, because at the end of the day, they're our future. And actually, the more we can utilise that area from primary right through to secondary, through to colleges and universities, so that it looks better. So again,
and we're pushing on an open door with the schools, and I'm having a lot of conversations with the Office of the Commissioner of the Future Generations Act as well, because obviously Derek's working on his refresh at the moment, and working very closely with the Deputy Marie in terms of how we can use the model that we're creating here, really understanding the value of prevention, both in terms of outcomes for our community, but also the return on investment, the economic lens of public health as well. So that again will help our future generations and children focus.
the final bit is vaping. What is being done or needs to be done, or can we suggest the government might do to stop this area of activity, particularly amongst young people, and also the shops that are developing, which seem to be more and more in the community actually for selling these vapes. So are we anyway, or what are your thoughts on what can be done to again prevent this from becoming quite a big issue for people's health in the longer term?
It's a massive agenda. So about 6 weeks ago now, I went to the Parliamentary Roundtable, which was so I was there as the public health consultee on the new smoking vaping bill that's going through Parliament at the moment. So I was able to give a very clear public health perspective into the bill. It's a complex area because obviously e-cigarettes were originally put on the market as a smoking cessation tool, as an aid for giving up tobacco smoking. And we do know that vaping is a good tool in terms of helping people come off tobacco. However, what we've seen behaviourally, see I'm using the behaviour word, is that it has almost become a replacement for some people from smoking. It's been replaced with vape. We're also seeing that profile, as you're indicating, Paul, in terms of young people accessing vaping. And I think the point is, when we talk to young people about it, they generally think that they are inhaling steam. They do not realise that what they're inhaling is nicotine. and that is an addictive substance that has an impact on your brain and your brain development. So I think there is something about the messaging in terms of what we understand the impact of nicotine addiction and what that does, and really start to understand that actually vapes are there as a smoking cessation tool. They should never ever have been there, being available as they are. However, we do have vaping shops, and the regulation is very, in trying to walk this very difficult line between not removing vapes as an option and making them harder to get to, because the challenge of that is if cigarettes become an easier option to get to, will people go back to tobacco smoking, which is more harmful? So this is the dilemma when we did the roundtable with the parliamentary review. This was the timeline that we were working, but we do have to regulate in terms of children accessing them, because what we're actually seeing is it's a very slippery slope. Children are now so addicted to nicotine that they can't get through the school day with vapes, nor can they vape without being seen. So they are using other tools to access nicotine. So there is a real shift in terms of access to nicotine and the increase in addiction of nicotine. So we need greater education with our young people, that they understand that what they're taking on is a drug and it is going to have an impact on their brain development. So there is work to be done, and we are aware of it. We're holding a session tomorrow. The public health team are doing a webinar tomorrow about vaping, public health crisis or crisis or cure, trying to balance that debate in terms of the reduction on tobacco smoking and nicotine addiction. So have they become another public health issue by virtue of actually what they were here to do in the first place isn't actually being carried out? There is also a Four Nations special interest group that's been set up to look at this, which is a collaboration between the Royal Society of Public Health, the Faculty of Public Health and the Association of Directors of Public Health. And that Four Nations special interest group is now meeting monthly so that we can work alongside the development of the smoking and vaping bill to see how that's implemented on the ground. So it's a really busy space, but a very complex space as well.
And well done, thank you.
Thanks, Paul.
Bill and then Neil.
Yeah, thanks, Chair. Well, I have to say I've been reading these annual reports for many, many years. I have to say I think this one could be a bit of a watershed because it feels as if we're changing the debate, we're changing the language. There's this line about looking at the causes of the causes, for example, I think is crucial. I think what we've had previously have been a lot of top-down messages. You must stop smoking, you've got to get out and walk. I think this is more bottom-up because you're looking at, well, why are people smoking? Why can't people take exercise? And I think this will probably resonate far more with the communities that we need it to than probably many of the approaches we've tried in the past. I just think the change of language is really to be welcomed. I hope I'm not mistaken in saying it's a watershed, but I think this could really be the change of something different. So it would be really well done. Excellent report. But I think it's excellent because of the messages and the way we portray them. There's something different in this. I think it's quite superb, really.
Thank you, Phil. Appreciate it.
Yeah, I think you stole my point.
Oh, sorry.
Let's say it again.
Let's say it again.
I'd like to.
So
We need to say the positives more than one.
my way, yes. So I'd just like to echo that. I think it's very bold and visionary, and excellent report all around. Connected to that point, it is about communities and it is about changing the relationship with communities. And I just wonder whether we're able within this new plan and direction to be able to get feedback loops from communities in terms of how it is playing out from their perspective, so that we have got that constant feedback loop and growing engagement with communities so that we're taking them with us rather than like imposing something on them.
And that's exactly the approach, and that's why the community conversation approach is that, because it is a conversation, it's a continuous one. And so it is partly community engagement, but it's more than that, because it is that constant feedback. And we found this with last year's report where, the recommendations weren't set by me, they were written by the children that we've engaged with as introductions in terms of the work that we needed to do around improving the outcomes for babies, children and young people. And the same will happen with this in terms of the way that we work with the community to take this forward. it's pointless doing public health if it isn't aligned and embedded in good community practice, because it's not about us. It's not an academic or professional exercise, although that's how the discipline behaves. It is about the communities that we serve, and we have to start to take that seriously. It shouldn't be a separation. And there's been a lot of work within the team over the last couple of years. You know, we've done a whole new structure around that, trying to move the team from public health policy department into the public health community thinking department, where, you know, the phrase I've said to the team a lot is get out of your heads and into your hearts, because that's where we need to be doing good public health practice. And whilst the annual reports obviously are annually by virtue of their title, what they do then is instruct the work that we do, and each one will let you know the work around babies, children, young people hasn't continued. That's now informed the National Children's and Young People's Framework that I'm developing with Public Health Wales. So they will just continue to inform our development plan continually, but making sure that we're then delivering, you know, our ambitions as board against the IM2P.
Thank you.
Thank you. Penny?
Yeah, thank you, Chair. Thank you, Tracy. An excellent report, quite thought-provoking and quite different from others. But by taking this approach, do you think that the quite startling disparity between the age groups between those affected by ill health, for example, between Blaenau Gwent and Monmouthshire residents, will be affected, will be reduced significantly as a result of, as Phil has said, from starting from the bottom up instead of the top down? Do you think this will help to reduce that disparity?
I really hope so, Penny. I think one of the things that has struck me is how passive we are. You know, there is a lot of information out there. I mean, the data's incomplete. You know, there is stuff we don't know, but the data that we do have is really, really stark, and the gaps are not acceptable. And I think for me, there is something about it's time to start and get angry about these things and stop taking a passive approach to them. You know, we've got real information and real instruction about things that we can change in terms of the people that are dying before they should. So if we take stroke, for example, we know that 2 out of every 4 strokes are likely to be caused by high blood pressure. And we know that 1 in 4 of our population that are living with high blood pressure don't know they have it. So a simple thing like understanding the level of high blood pressure in our community could prevent 25% of our strokes. And we're ignoring that fact. And I think we need to stop being passive about these things. We know things, so therefore we should do better. So I think there is something about seeing this start data and actually not thinking, oh, that's awful, isn't it? And being passive about it, getting angry about it, know our purpose and make the change. So the data, the starker it is, I think the faster we need to move on it to make those changes, because if there are lives to be saved, then we should be saving them.
Thank you.
Thank you.
Are there any further questions? Well, thank you ever so much, Tracy. It's such a welcome practical change in direction that you've presented today. And we have seen the impact of last year's report already, but this is truly a step forward to take a very, very different approach to improving the health of the population. And I'm really, really pleased with it. Thank you very much.
Thank you.
Thank you. And I hope all goes well.
Thank you. Thank you very much. See you all later.
See you later. Can we move on to 4.1, and thank you very much for waiting. And I'm pleased to welcome today's meeting members of the Patients Advice and Liaison Service team who will share an experience story with us. So there's Joanna Hook, Daniel Saunders and Michelle Jenkins.
Hi everyone. So I'm Jo Hook, I'm the senior nurse for the patient experience and involvement team. Joined, like the chair said, by Daniel and Michelle, who are part of our patient advice and liaison service, or more widely known as PALS, which was established within the Health Board in November of 2023. So the next slide, please. So the PALS team covers the Health Board wide. As I said, they launched in November 2023. They're made up of 3 PALS officers and 3 patient support officers, or PSOs. We cover a 7-day service, including bank holidays, and work 8 AM to 8 PM. The team offers confidential advice, support and information for health-related matters, and they manage the case or their cases as a whole. So it'll come into us from various sources. It could be from the patients, families, from clinicians, could come from our from SLICE or our MSMPs. And we will only in-reach then into the clinical services if we need that specialist advice. So it is about releasing that clinical time. So if we can solve it within the team, we will. If not, we make that initial contact with the patient or the family, find out, what is their concern or their issue, and then in-reach into that particular service, ask for their advice, or if they need to make contact with that family, and then we'll take that call back over until this resolved. Each of the PALS officers and PSOs have a champion link role as well, so they become knowledgeable in a specialist area. So we've got learning disabilities, mental health, dementia, equality, diversity and inclusion, because that helps them with the nature and the types of calls that are coming through to the team. So to date, so from November 2023 up until I think Monday of this week, the team have supported 9,196 patients and families. And that's a mixture of inquiries and early resolution concerns. Only 26 of those cases then have needed to be escalated to the Putting Things Right team for a more formal process. So that equates to 0.28%. Next slide, please. The type of support that is offered by the team, it varies. So we've got inquiries, our early resolution and the complaints avoidance. But we also do things like listening meetings that would previously may have gone down the complaints route. So it's just listening and just allowing that patient's voice to be heard. And it can be various things that we've met with families that may have lost a loved one but have questions and need that closure. And we will then facilitate between the clinical teams and the families then to enable that meeting to happen. And sometimes one case we had, some of the family live locally, so they were able to come in for the meeting, but a daughter lived in New Zealand, so we were able to work out virtually, with the time scale for allowing everybody to join that meeting then to be able to ask questions. We'll attend appointments and we offer the pastoral support. We'll refer on to volunteers and use the volunteer service within the health board. And we're also a dedicated point of contact for end of life and bereavement. So our calls come from various routes, and I've shared that, and they vary in nature. So we've had our quick turnarounds will be locating a patient. Somebody's been admitted into the ED department and they don't know where they are, so they'll ring in and we can locate them. And then we got more complex ones, so patients that are far from home and they'd like to move into a different hospital, so we're aiding with the transfers and linking in between the clinical teams if it's appropriate, that we can get that care closer to home. We'll support around discharge if there's any discharge concerns. Sometimes patients don't want to go home or want to go home, and it's that breakdown of communication that's been able to support then between the clinical teams and the families. And we've even supported a patient that was admitted into hospital, and his biggest concern was his cat. He had no family, no friends, and who would feed and water his cat. So we were able to support with that until the cat was taken then to be looked after until the gentleman was discharged. I've shared that some of our calls are very quick. We can turn them around, in minutes, and then other calls we will keep and support that patient for many months. For one example is a lady that was admitted with an infection that led to sepsis and ended up that her dominant hand was amputated, and then learning then to adapt. She did have a family member who then got into a very nasty accident and wasn't able to visit because she was then admitted into hospital herself. So the PALS officers then were able to support with ongoing concerns. And I think with her mental health and helping with there, and until we were at a point then that we're able to refer on to our volunteer teams then to be able to support us. Every call that comes in to the PALS team then is entered onto Datex. So we're able to then look at themes and trends that are coming through from that data. We can link in them with specific departments, directorates or divisions. And we take compliments and anything that's, good practice or compliments that are shared with us, then we will share with those individual teams and the divisions. So the next slide I'm going to share then is a short film that highlights the PAL service.
PALS officers handle more complex queries, often involving patients and families who contact the Health Board to raise formal complaints. The team works alongside the broader support of the Health Board to address and resolve concerns, aiming to avoid a formal complaint process whenever possible. Source referrals is very wide. We get them from GPs, we get them from the wards themselves, the staff, senior nurses. We get them from Llais, the Advocacy Service for Wales. Some come from our Putting Things Right team. And we get them from our corporate team if they come through a Member of Senate, Member of Parliament route. So very wide kind of variation of where they come from. And then we see them through then to completion. Sometimes it could be something we can close within a day or two and support, or it can be some that we've had for months and months and months. It all depends on what the case is. We, again, with the support, we offer support for people very wide, some living in this borough, some as far away as Australia and New Zealand. We kind of get them from all areas, really.
We can have calls off patients looking for relatives. If a loved one has gone off in the ambulance and they don't know where they're gone, we can pick up those calls so we can locate the patient for the relatives. Another kind of call we can have is a patient that's actually in hospital and they are looking for our support to help them with any concerns they have with their care.
PALS officer received a call from a distressed mother living in Ireland. Her son, studying in South Wales on a football scholarship, had gone to the emergency department in severe pain. He had contacted his mother to say the department was too busy and he planned to return to his student accommodation instead. Worried and unsure how to keep him safe, she reached out to the PALS team for help. The PALS officer reassured her while coordinating with a PSO on duty, who immediately went to the emergency department. They found the young man preparing to leave and convinced him to stay, explaining that he would be seen as soon as possible. The following morning, the PALS officer followed up with the mother. They were informed that her son had undergone an emergency appendectomy during the night and was now recovering in a ward. Grateful and relieved, the mother shared,
"I am so grateful you were at the other end of the phone. It was such a weight lifted off me, and I was able to sleep last night when I had originally thought about booking the next flight to Wales."
The PALS team is a wonderful support for the whole of the Health Board. They're there to support us and the patients, and they're an invaluable resource.
My name's Ellie Jones. I've had a previous poor experience at the emergency department. I'm autistic, which means that whilst the emergency department is stressful for anyone, it's a lot more stressful for me because there's a lot of unfamiliar environment, a lot of noise, and this can cause sensory overload or even a full shutdown. I was directed to the PALS team, and I've been working with them recently to try and look at ways in which the ED can be made more accessible for autistic individuals or anyone with additional requirements, whether that's neurodivergence, a cognitive impairment or anything else. Following this, it's resulted in a poster so that people can let staff know if they've got any additional needs. I was also taken on a walkthrough of the ED when it was less busy, which means that if I have to go there again, I'll be a bit more familiar with the environment.
As part of my role within the PALS team, I've been supporting a patient and his family as he's been having issues with some of his care on the ward. As I've been supporting the family and the patient, it's been identified that there's been the need of some bereavement support. So that's why I linked in with the bereavement team then to support the patient.
I've been able to visit the ward and offer bereavement support during his inpatient stay, and I've still followed that at home now as well.
We work in very close contact with the PALS service. They are the missing link in an Iron Bevan that has filled a huge void.
Hello, my name's Amanda. I'm from the Patient Advice and Liaison Service. I understand you're having some problems with the care that you're receiving.
Yeah, I am. Thanks for coming. Take a seat and I'll explain what's happening.
They provide a service that filters really in when we see gaps. So when patients are in, there's a high demand on services for nursing. The PALS service will go in, they'll often sit with patients, they'll help out, they communicate with families on behalf of the ward and on behalf of the families out there to the ward. and they really are a gold level service that we can't do without.
I'm able to take volunteering time through work, and they've agreed that I can use this to work with the PALS team to try and improve experiences for anyone with additional access needs, and I'm really happy to be able to do this.
You can just go to the next slide, please. I'd just like to share with you some of the from the feedback that we've received from our callers and how we've responded. So the first poster over on the left-hand side is what we shared in the film following the feedback around neurodiversity and the emergency department. So this is the poster now that can go up, but this can go up into any department or ward, and we just need to change the ward name or department name. But this is something that, you know, I'm working with Ellie, who's got that volunteer time from her own job, you know, to support us, along with other people that are neurodiverse and staff members. We're able to make those small changes and improvements and linking in then with staff. The middle one then was one of our earlier posters. This was feedback from a family that when they came to visit their mum in hospital, they didn't see the nursing staff. And then through the communication with the ward staff, then it was that they didn't like to interrupt when families came, but they were always on hand. So the suggestion was then if we could put posters up then at the bedside to say that when you are visiting, we want you to have that time with your family, but that assurance is given then that we are on hand if you do need us. So that was, then the third one then, this is something that's new, I've just ordered them, they're A5 and they're stickers, and I've linked in with facilities and the infection prevention and control team, and we're going to have these on every bedside locker across all the wards. So patients then, if they're in the bed, they know how to contact the PALS service, they know what hours we work, and then we got the email and the phone number, and then we can put them up then in outpatient areas as well, so anybody will be able to reach us. Next slide, please. So our next steps then, so we work closely with the Putting Things Right team. There's a lot of work, a lot of our calls come over from the Putting Things Right team, so we'll continue there. We'll continue to meet with the directorates and the divisions. We do a lot of presentations to ensure that they understand our role, a new team fitting into a big organisation and how everything works. We wear bright orange t-shirts, so we like that visibility. I'd like to get them out and about more onto the ward so the patients and families and the clinical teams know who they are and can approach them. The PALS team also support the Civica patient feedback service. That's all our surveys and questionnaires that go out. And then we look, and if there's any true compliments through that feedback, the comments left on the surveys, the PALS team then will put those in through to Datex so we can capture all those compliments, and then we're going to add them then to the wall of thanks as well. Raising the service profile, so as I shared, one of the ways is having those stickers out and about so people get to see and know who we are. We are now working with the Call for Concern team because a lot of the calls that they've got would have probably been PALS related, so it is raising the profile of both teams and saying if it's this, you go to this team, and then if it's that, then you can come over to the PALS team. And then we're working now, so we've got the new patient and family support officer that works within the PALS team, but is specific around end of life and bereavement. So that's a new role that's come in the last few months. And also the PALS team then will be supporting the people participation panels. So we've had the one around neurodiversity and the emergency department. We're looking at dementia, sepsis, and various things. So we have a mixture then of lived experience, staff members and independent members then can join, and then we can work on improvements and what's required. And next slide, and thank you everyone.
Thank you very much. Extremely helpful and very interesting indeed. Are there any questions, Joanne? I think yes.
Just to add on, I think you know, clearly those 9,000 contacts is 9,000 times we've saved clinicians. Perhaps you know, either these ending up in complaints and therefore clinicians investigating, or taking perhaps clinical staff off the ward to deal with those inquiries. So it's a real opportunity. We're going to do an evaluation to try and see if we can quantify some of that, but I think the impact is significant. And the other piece of work that Joe does is to make sure that we connect with the volunteers. So the green T-shirts was a volunteer. So we connect very much in our volunteer capacity and support to the team as well. And we've got 300 volunteers.
Yes, there's a lot of volunteers, yes. And lots more waiting to come in as well. They're applying. Yes, it is good.
Excellent. Thank you, Jenny.
I just say, I mean, I think it's a huge, great success story, really. I think that from the presentation, it looks like a sort of wraparound service, really, for the patient, which I think sometimes, you know, when you are vulnerable and in that situation, having somebody you can talk to, I think is incredibly helpful. And what I liked about the volunteers to champion sort of inclusivity, and particularly some of the sensitive areas like end of life and also bereavement, which are incredibly difficult for families, etc. But also taking a balance between compliments and complaints and looking to seek areas for improvement rather than just focusing on complaints. So the people participation panels are particularly, I think, helpful as well. But is there anything we can do to help you for the future, I suppose, is the question I wanted to ask, other than to say well done and congratulations to all your team. Anything we can help with?
Thank you, firstly. I think it is about raising the profile of the team. So that's what we're working on now. But if any ideas or any support with raising that profile, you know, that's why we thought with the stickers. I was trying to think of something of how do you reach the patients who are the most vulnerable, that might not have family or friends, that are just, they're not quite sure what to do. So that's what we thought with the stickers. But any ideas or support about raising the PALS profile, you know, so that we can help more people would be ideal.
Great, thank you.
Rob and then Bill.
Yeah, thanks for a really powerful presentation. Thank you. I was really interested and surprised you mentioned about some of the cases of months and given the examples you quoted. Do you link up with social care at all? Or the third sector for support in the community?
We don't tend to know. The cases that have been open for months can be a specific scenario that I'm thinking of straight away is a lady, she lost her husband, very, of course, traumatic circumstances, of course, but she had a lot of questions, but she did not want to go down a formal route at all because she wanted the footprint to be quite small, just because of confidentiality. And she came to us, and that was saying that went on probably about 7 months, I think, maybe 7-8 months, because it was only going to be me. I kind of contracted with her almost to say, look, it's just me. So what I need is your patience, and we can work through all of this. You know, we need to enrich a little bit, but that was with Joe, because Joe's got a clinical background, accessing the health records to go through specific questions. And because it was just me with that, and we got many other cases as well, like I asked for her patience, which she was happy to give. And that went on for about 7 to 8 months. So that was a case then that was just always in the background. And I closed that 2 months ago, I think. I mean, the gratitude from the lady was immense. It was extremely moving, and one of the reasons why, like, I love doing the job. That was one of those moments, but that was a long case. It was quite difficult for me then to close it down, because it was like I'd been with her through all that, and for her to have got exactly what she needed to move on without having gone in that formal route. Like I said, that's why I love the job. So yeah, that's an example of one that went on for months. It's not necessarily about care then, it's about someone getting that closer.
Supported, yeah. I mean, we do link, you know, we can link with third sectors. We've got a direct number and a contact with the Department of Work and Pensions. So if people do need that support, so it's so various. It varies so much. We do not know the types of calls. Yes, we do have our usual ones locating the patient. I mean, you probably take lots of those, Michelle. Yeah. But the nature of the call, because there is no criteria to ring us, it is just the variety. It is huge, isn't it? You know, that's what we take. But we do link. We are building up our networks now over the last sort of 12-18 months to be able to know who to link with. We all come from different backgrounds. So I'm primary care and community, so I've got links there. One of our teammates come from the mental health division. So it does help them with networking and knowing then who to go to.
Okay. Brilliant service. I mean, it almost sounds like a care management service for the patient, really. It sounds superb, but I just wonder, how do you manage that clinical interface? I mean, if you've met with the patient at the bedside, as we saw on the film, a patient might give you information about their care which they're not happy with. How do you actually handle that crossover with clinicians then, that you're you're knocking the door of the clinician and saying, well, Mr. or Mrs. whatever is not happy with the particular aspect of their care. And I just wondered, how is that received? And how do you actually manage that? Because that's where, I guess that's the tech. You must be very skilled in terms of all of the relationship work and all the rest of it, because that's what this job is really about, isn't it? But I just wonder how you actually manage that, because that must be quite difficult.
I think it was at the very beginning, it's the networking, it is knowing people, it is then sharing what we do and why we do it and what our position in the organisation is, you know, that we're not quite putting things right, but we're there to aid and support. So I think it has been relationship building has been the biggest one. I mean, I'm lucky that I'm a nursing background, so I've worked in the acute as well as, so when people know you as well, I think that helps. But I think the team, their approach, it's not blame, it's that we understand what's going on. But Mrs. Jones has just said to us, these are the things, is there anything? So I think it's how the team approaches, and they've got to be, you know, very proud of how they approach people. I mean, Michelle, the team often message me and say, I'm listening to Michelle on the phone and how she's managing, you know, the staff or a patient, but she's just brilliant. You know that, and Michelle's been doing it a lot longer because the patient support officers were around before the PALS team, taking a lot of calls during COVID around locating patients. But it is about relationship building, but it is down to the individual members of the team and their approach and building that relationship and that trust with them, with the clinical teams.
And I think with like when we pull our data, clinical treatment, even though it comes out on Datix, you know, as a theme, is not the highest. The highest is communication, because a lot of the time, even though it looks like to begin with is clinical treatment, is actually communication. They've been saying very quickly, and you know, it's like when you know what you're talking about, you just assume everyone else does. So then a lot of clinicians might say something very quickly, someone is trying to take it all in, they're completely getting the wrong end of the stick, understandably. And that's leading to that massive concern, you know, that urgency as well. So whereas it might sound like it's clinical treatment, like assessment, is actually the communication. And what we do is we go in there and we bridge that gap then. So like I said, yeah, a lot is mainly communication.
And I think we're driven by patient experience, because we're the patient experience team. So we're not driven by targets, we're not driven by, you know, set by Welsh Government. We are driven by when, you know, the team can ring me because I'm their clinical support. And bottom line always is, what will be the best experience for the patient? If we're not quite sure what to do, that is always our default. And then we take it from there and move that forward.
How have you been trained to undertake these roles?
Well, Daniel's got a background in counselling. So,
yeah, my background is counselling psychotherapy. That's my background, which is like, I don't blur the lines of it. That's a separate thing, but that is my
around the communication though.
So that's my background outside of this. Yeah.
And there's, you know, every team member when they join, we have a full induction. They do the volunteer induction, so they get to know with the volunteers and have all the trainings available to them. They do stage and time training, any communication, managing difficult conversations, any training that I can find, like our goals, MCA and consent, anything that would be relevant, or the safeguarding training, dementia training, anything. So we are always looking for training that would be suitable, because we don't know what the call is going to be coming in, and we can take from birth right up to death and everything sort of in between. So our new patient and relative support officer has just started one of the health board's basic counselling skills course. So that's something else. So we're always looking, you know, but a lot of it is around communication, but also just having a little bit of knowledge of different specialties, and then that builds up your network and your links then, so we can reach out then for support.
You?
Just a quick, probably not one I need an answer to now, but one we might think about. You've obviously seen 9,000 odd, I'll call them issues for now, or things that are going wrong or not, things that aren't quite to the patient satisfaction, etc., etc. If you could, what are we getting wrong that generates a lot of these? Is there anything you're seeing that you think, oh, not that again?
Communication.
Communication is always our, it's, people are busy. And like Daniel said, then abbreviated, we talk in our, you know, organisational lingo is, you know, that compassionate communication, you know, what else would I change? I'd have a huge team. I'd have bright orange everywhere, you know, to get out there to work, to support the clinicians. I've been a nurse for 25 years. I know how hard it is. You know, I've worked, like I said, across lots of divisions. But yeah, communication would be how can we communicate? Because a lot of our calls are around that.
Okay. Are there any processes or systems you're seeing that are holding us back as an organisation, or? As I say, you're right, I can't answer that now. But you're at the sharp end of it. You're seeing exactly right from the patient.
I suppose a lot of our calls, you know, for like Michelle's calls, is locating a patient. Is there anything that we could do that when somebody's coming in as an emergency, how do we get, you know, how do we get their family member, their next of kin to know where they are? I mean, if we could solve that one, that would, because that's a huge number of calls that come in. You know, you could be out shopping, you've suddenly, you know, had a heart attack, you've been taken in, and then we're making frantic calls. It's a huge area. You know, is it through the emergency department? Is it through our acute medical units?
I also think that it's like with the communication, it's not, it is the issue, obviously, but that's what exactly we're here for as well. So, you know, it's not like a complaint that's going into a formal room, you know, after the fact. That's coming to us, and then we're improving our experience right there and then. So we're kind of doing that thing, which is actually the issue comes and then we resolve it there and then. So we are doing enough in a way, because we're the people who are like picking up between the gaps like that and actually making that communication and just getting it at the source and then making that patient experience when they're in the hospital. I mean, that's the joy of it, you know, is picking that up, because it is extremely high pressures environment, obviously, on the wards. I'm currently working with a gentleman who's on a critical care unit, and that's very high intensity, but I can then visit him and go visit him, like go back to the Grange now and provide that extra support, you know, and that's, so we're kind of doing it already, you know. We say about what we could do, like we kind of are doing it. And I think that's measured in the fact that then they're not, I mean, obviously we're going to get complaints coming in possibly, but they're not coming back and saying, well, I had no communication at all, because they did, because it was us.
We know the ones we've resolved that would have gone to a formal complaint if we hadn't. You know, we always say, if we can capture somebody that's, you know, struggling whilst they're still in inpatient especially, and improve that experience from that point onwards, as Daniel said, that can then avoid that complaint. It's when a patient then goes home and then contacts us, that's where we can't improve the experience they're having at that time. So that's why we got our posters up, and we want to get our message out there so we can get to them as soon as possible whilst they're still utilising our services, because we can make that improvement then. I'm not sure if I answered your question.
Sorry, I'm the same as well.
Nick? Yeah, just to kind of sum up really, you know, really pleased with the way the service has kind of developed and emerged. It was such an important thing, isn't it? We know that, like you say, I think particularly communication, people not knowing where to go when they're not happy and they're in the kind of process of care, and people reaching out to social media because they don't know where else to turn. So I think having that power service there is absolutely delivering what we hope to, and lots more to do, I think, in this area, isn't there, as we in other parts of the whole parts of the health board. But I think the numbers speak for themselves in terms of, you know, I've spent some time with the PALS team, and it's, like you said, the variation is, you can't properly describe it, I think is fair to say, isn't it? But yeah, I'm really pleased with that communication bit. I just don't think we can ever get enough of. But I think picking up those themes and where we can make more systematic changes in is something we need to continually look at. And I think come 18 months and doing a kind of proper evaluation of what we've learned and what we can do. And I think the biggest thing is, as you said, is raising the profile of it. It'll be these victims of its own success then, but lots of people still won't know about it. And I think the more we, like, the stickers is a fantastic idea to get that number, that contact up there so people can reach out when they really need support. So also well done, thank you.
Thank you. Thank you very much for coming this morning. It's a grand scheme. Being one of the first to put it in England, I was very pleased when Jenny suggested we do it here. So I've always been a massive supporter of health schemes. And thank you very much. And sorry we delayed you on your important vote.
Thank you so much.
Thank you.
Elegantly. Sure.
Thank you all.
Thank you.
Thank you, everyone.
Thank you.
Bye.
Thank you.
Thank you. Might we now move to 4.2, report from Llais and Lisa?
Hello, good morning, everyone. Hope you're all well. Okay, just to give you a flavour of where we have been and what we've heard over the last 2 months, so the first quarter of this year, really, in terms of our Gwent advocacy service. And I'm smiling just hearing PALS because we've worked quite closely to look at the right referral at the right time to ensure the right support at the right time with both PALS and PTR on ourselves. So that was a really good presentation this morning. We've seen a peak around people contacting us, particularly in terms of GP services, around access to appointments in particular that Nicola brought to our attention this morning, in particular with regards to the partnership with Dr. Allison and Dr. Mohammed. That remains the highest area of concern that people wish to raise formally. We are trying to look at early point of contact around resolving people concerns to prevent more formal escalation so they get the right care at an earlier point of contact, and we can share that information with practices and decision makers. Just to move you through the report, really, we have focused on representations, firstly primary care services that really have been of significant concern from kind of the end of last year to the beginning of this year. And we've carried out a series of on-site visits to very much focus on people and community voice around the partnership in question, but also wider GP practice concerns. For us, it's about remaining factual and to look at the wider picture across the GP practice in Gwent, but also we're doing a piece of work across Wales that I'll be able to share with you come summer of this year. I guess the outcome of those sessions and the public meetings that have been taking place have triggered the response with the practices, Nicola said earlier, have returned the contract. However, we have had a very good working relationship with key people across the health board, particularly Lloyd Hambridge, Rachel Prangley, keeping us informed and assured with regards to contract compliance and patient safety. So thank you for that. We've also had very timely response around our representations that we've submitted, in particular around access to appointments, the 8 o'clock bottleneck, if you like, and the NHS app, very much looking at how this is going to be addressed and rolled out, not only for the practices that have now been returned to the health board and managing expectation around that, but also wider practices. And we've also been connected with the GMS contract target review to ensure that patients' voices influencing those targets. So again, things are challenging, but moving forward, I guess I'd like to just share that with you. We've also done a key piece of work on mental health services. So you're aware that one of our priorities for 24-25 was very much focused on mental health. We know the challenges that we've had with children, young people services and adult services within this area of work. We have received a presentation from the Mental Health Directorate and are pleased to hear that actually it is moving at pace around increasing support and access to mental health services. We have had a series of individuals in inpatient care contact us around patient safety. However, we have carried out now a series of inpatient visits across a number of areas, and the feedback is mostly positive. We have shared the outcome of that report with Director of Mental Health, who is keen to look at getting under the skin of some of the areas that we flagged, but we are assured it's very much in progress. And for us, it's around I guess just feeding back to wider people and communities of changes that are being made. We've also have live, it will close the end of this month, our mental health survey that's reached people with a nice mix really from the age of 16 to 87. And again, what we're hearing is that individuals are expressing frustration with the accessibility of services, which are often required navigating through GPs for referrals, but the difficulty is they are struggling to get a GP appointment in the very beginning. So it's kind of a full loop really in terms of GP concerns and access, and also contact with mental health services. They talk about inconsistent communication with common concerns that Pal's highlighted earlier. And some people were highlighting the lack of direct contact options and the need for a more streamlined triage service. And there was additionally concerns around quality of care, particularly for those on the autism spectrum disorder. However, there were some really good experiences shared, in particular around the work of the 111 option 2 and counselling sessions. And that, I have to say, has been consistent with what we're hearing throughout all of our community listening across the Gwent footprint. So that really is making an impact on people's lives and indeed mental health. Just in terms of engagement, we have we hosted in January, and many of you were joined us for that event at the Parkway Hotel, and it was based around until it happens to me. So professionals walking in the shoes, seeing and feeling impact of services and what could change from now into the future. So the kind of links with the theme that the chair and chief exec mentioned earlier is about future planning and what next. And that was really impactful, and people were really honest and shared some real quite powerful stories of their experience of health and social care services in Gwent, but also what could change. So I've included in the report a summary of those findings, and I hope that will absolutely influence how we move forward across the health and social care footprint moving forward from 2025 onwards. We've also been out and about and had quite a high presence the beginning this year in our communities across Gwent, and we are looking to progress that approach moving throughout this year. We have adopted a new way of engagement. It's real solid traditional community development. We're going to people where they are, partnering with schools, third sector groups, community groups, but also our health premises. So we are out and about and really talking and listening to people to understand both challenges, but also what works. So that has been quite powerful for us, particularly about gaining the voice of children and young people and wider community members. And it was really interesting. I just wanted to share this with you, and I know you will have this formally. We went to Cwmbran 2 weeks ago and engaged with a high number of children who attended the school there and their carers. And one of the little girls, she was 6, had to wait a year for an appointment to see an audiologist. She couldn't hear anything. Actually what happened was, after the appointment, she was given a hearing aid after a year. And then the little girl talked us through how that moment was for her. So walking through the park for the very first time with her glitter pink hearing aid, she looked up at her mummy and said, "Mummy, I can hear the birds tweeting." how powerful is that? So it's just about going and understanding and listening to people to really hear what works and where we need to make improvements. So we have a series of those coming up, to which are shared with the Aneurin Bevan comms team. So if you do wish to join us, please do. Nationally, our focus has been on 2 key projects for the end of last year, beginning of this year, to which I've circulated. The first of that is Same Day Urgent Care Project. So you will be very well aware that Slice Wales were out and about in 42 hospital settings across the Welsh footprint at the end of last year, and spoke to over 700 people to really understand people's experiences around emergency and healthcare. It was quite hard to hear in parts of it, but I think the conversations that I've had with Aneurin Bevan and particularly Leanne has been reassuring that we are aware of the challenges, and there are plans in place that I know are on the agenda today to be able to provide a response to some of those representations that have been made within that key document. The other piece of work that we have been focusing on is very much around social care research. So we've commissioned consultants called the STOP Collaborative and Listen Agency. They're very innovative in how they engage and listen and hear people to be able to escalate change. So that is currently out live as a survey, as a focus piece of work. And thank you to all who have supported that. And it's very much focused on understanding regional variations and identifying barriers to effective service delivery and highlighting areas of good practice. And I hope that that really will feed project planning for Aneurin Bevan and RPB moving forward around the bigger picture across health and social care. So that research will conclude March of this year, and then we will be able to share our findings to be able to influence a level of change and share that good practice. Thank you. Are there any questions?
Thank you, Lisa. That was very helpful. Has anybody any questions? No? No, you're off the hook.
Thank you, Anne.
Thank you very much. Thank you for that. That's very, very helpful. Could we go on then to, if I can find the agenda? Oh, the IMTP. Thank you. How could I forget?
Thank you. Thanks, Chair. So the IMTP is presented to the board today for approval. Board members will be aware of the requirement set out in the NHS Wales Finance Act to receive and approve a balanced IMTP. So that's the context within which the plan's coming forward to today. We have been through a number of engagement touch points. Board members will have previously seen detail and commitments via development sessions and committee sessions as well. Important, I'm just going to give a bit of an overview of the context for how the plan's been developed, some of the sort of detail of what makes up the plans. I appreciate there's an awful lot of information in the board book, and then set out some of the key priorities before handing to Rob, who'll give an update on the financial elements of the plan. So I'll try and keep it brief, but to do it justice really, as it's a key important governance document for us. So the plan has been developed in the context of our escalation status. I think it's important to state that we are in escalation for finance and planning. So it's in the context of the progress we've made throughout this year in addressing some of the issues and de-escalation criteria. So most notably in this context, the 3-year route map and the work we did on the hospital systems Grange report. And in terms of our approach to planning, the requirement and the action we've been taking around the planning maturity matrix. Also, the context of the escalation of enhanced monitoring for urgent emergency care has obviously driven and informed those sections of the plan where we build on and take the next steps of improvement against that escalation status. And through delivered this year, we take forward some of the significant progress and look for sustainability, particularly you'll see as we come on to talk about areas of mental health, but sustainability in performance areas and service changes. And an important then context for the plan development is the national requirements, so the NHS planning framework and the expectations set out in there, alongside our local priorities and the emphasis and the focus we want to give locally, which we've seen and heard some of this morning, particularly in context of Tracy's presentation at the beginning. So in that vein, then that's what we've tried to work through on an iterative basis with teams across the organisation, trade union colleagues, been to the LNC, key stakeholders and teams to try to find a way to balance all of these requirements, put a credible plan before you. In terms of the plan itself, as I said, there are a number of keys. So there's the document itself, which, whilst there's a lot of detail, it can still only be a certain level of detail, recognising that at a divisional basis and a programme basis, we have further layers of granularity underneath. There's also a suite of appendices that are required, which you'll have set out in the board book as well. So what our delivery commitments against the ministerial priorities, so performance expectations, delivery against the ministerial enabling actions. This is a new requirement this year that has come through the planning framework, where we've been asked to be quite explicit on our deliverability against a suite of productivity, efficiency, service change, sort of high impact changes. So they are referenced throughout the plan and summarised, but our experience with Welsh Government over sort of getting to this point is that they are putting quite a significant emphasis on those enabling actions. They have a suite of ministerial templates for some of the policy areas. The NCN and cluster plans are a requirement to submit as well, and a huge amount of detail in the MDS. So that's the minimum data set, which has activity levels, workforce changes, the finance and finance detail as well. So the plan is made up a number of key areas. So just want to help people orientate around that. For continuity, in terms of the structure of the plan, we've built upon the service priority areas from last year to enable that, as I said, continuity and consistency, recognising that last year we set our annual plan in the context of 3 years, so trying to sort of keep true to that. And that's those 5 areas are just repeated for reference in the cover paper, and obviously our enablers, so our ambitions and intent around our areas of our quality improvement agenda, our digital agenda, and our capital and estate. So the detail of that is set out in the plan as well. So you'll see underneath of those sections, we're trying to be really clear, reflecting some of the feedback we've had from colleagues, also feedback sort of nationally in terms of use of that maturity matrix, to be clear on what are the actions and what by quarter are the improvements expected to be seen. So I recognise there is a lot of detail in the plan, and I just want to draw out what we see as execs as sort of the key priority areas. So hopefully you'll see alignment with some of the conversations we've already had and we're going to have throughout the board and indeed other committee meetings. So the first one really is that we want to really take that purposeful action now on place-based care, as Tracy touched on, moving it from talking about the concepts and the policy to, okay, so what are our places, what are we going to do, and how are we going to do it, and where are we starting? And as Tracy touched on, we're keen to start in the Blaenau Gwent area, recognising some of the needs of those communities, but the opportunities as well. Secondly, again, linking with Tracy's update from this morning, our agenda around the preventable premature mortality. So that features strongly in the plan as well. And we're really determined not to be sidetracked by some of the national sort of access targets, so that we lose focus on some of this really important work that it's been obvious to date that has landed well with colleagues around the table, and indeed linking with that the work on the women's health, which is both a national and local priority for us. And thirdly then, linked to that context is our improvements in the urgent emergency care system. We have an ambition to get out of escalation in this area, so real focused action, building on our next sort of suite of actions associated that with some big ticket items coming online next year to support that. Not just around the new ED extension and the opportunity with changing the assessment model and the transfer lounge, but all the out of hospital work as well we're doing with partners. We'll retain the focus on cancer. We have seen, and we'll see in the performance report, that focused targeted approach through clinical and multidisciplinary engagement has helped us improve our performance, but we're also keen, linking with Tracy's work, to get under the preventable mortality agenda here, and not least we've got the radiotherapy centre opening in Neville Hall. So a key part of our plan for early next year will be the successful opening of that, which is a key sort of landmark really in the regional agenda as well. Next, building further on our mental health progress. Again, we've seen from performance reports the huge progress made from the teams in terms of some of the targets, but now the team looking at really what's the vision, what are the models of care, and that will inform some of our estate work as we move throughout the year. Lastly, but not least, our planned care focus. We know it's a huge priority nationally, and significant focus on this, and locally significant progress and attention as we head towards the end of the month on Monday in terms of delivering our best efforts to get as close as we can to 0 patients waiting over 104 weeks. That focus continues into next year on both that the using the best practice identified through some of the enabling actions I touched on earlier, using the national work of SIN, so the clinical implementation networks, what learning can we take from that, but also recognising that whilst we've made good progress and will make good progress towards the end of this year, some of that has been through additional monies towards the end of the financial year. And so whilst we are predicting, as you'll see in the plan, that out of the 24 specialties we're expected to deliver the 104 planned care target, we're projected to deliver that in 20 and still have 4 specialties, which we've talked about in this meeting previously, where we've got some demand and capacity challenges. So as part of next year's plan, we'll work on sustainability plans for those areas, and indeed take any opportunities of any additional non-recurrent monies to improve that outturn performance as we move through into Q1 particularly. And there are a number of strategic items over and above what I've touched on that we will be delivering next year, not least finalising and launching our new organisational strategy, and that then will spin off the supporting documents, digital estates, etc. Service change work in the place of frailty and our care of the elderly models, and are we right-sizing the capacity, the bed base and the workforce, and delivering some key business cases as part of our ambitions around Neville Hall and St Willis. So those are sort of some of the key, the slightly longer than an elevator pitch, but those key areas of where our focus as execs and support as boards that we will focus on, notwithstanding the detail in the plan. I'll hand over to Rob to give an update on the finance bit before concluding on some of the risks and how we're going to track delivery.
Sana. So conscious the board has received quite a comprehensive briefing at a recent session, so I'm going to quickly run through an overview of the paper. As you can appreciate, an awful lot of detail and plethora of backing information pulled together for that, and I'd like to thank my team and the wider health board for contributing to that process. It's been quite a challenge, especially given the financial challenges this year and the other operational pressures everybody's under, but we feel like we got there with a reasonable plan. So the 3-year outline plan that's identified in the paper and the annual plan is basically a reflection of a revised 3-year route map, but it very much focuses on 25-26. That's where the most, understandably, the most level of certainty exists. So the financial plan is based on income of 1.85 billion. And there's a comparison in the paper with the route map that we previously developed. And for 25-26, we'd assumed that our position would be a £13 million deficit. The revised plan, obviously, as Hannah's identified, is showing a best case position of break even. There is a risk range potentially up to £25 million presented as well. We are going for and posting the best case position. It is an ambitious plan. And if you look at the comparison with the route map, probably the most notable change would be the income levels, but we did receive in this financial year £40 million recurrently, which we weren't expecting to, so that does offset that. Our underlying positions move differently to expected, with about £11 million adverse position driven by particular issues in 24-25 are reflected recurrently in our plans around acute drugs, specialised services cost pressures, and the shift of some of our savings to a non-recurrent level. Overall, our spending is below what we were expecting in the route map, so that's a positive. And our spending level, having compared with some peers, is not out of line with others across Wales. So there's a level of confidence that we're not overstating that. And then our savings from the route map was expected to be £38 million for 25-26. This current version identifies £40 million planned savings level. So the underlying position has been presented, kept by the drivers around workforce, CHC, medicines management and specialised services. You can see the £27 million position there. In terms of income, they said we've assumed 1.85 billion. That's the 1.77% uplift from the allocation letter. That's some anticipated allocations, some of which we get recurrently, but each year, and some more speculative in nature, about £14 million, just to note that. In terms of cost pressures, where we have got local business intelligence or local analysis, we've used that intelligence to form inflationary uplift estimates and volume growth estimates. Other than that, we've used some national estimates or the 1.77% determined in the Welsh Government allocation uplift as our demand and volume growth cost pressure. So in terms of key drivers, there's a similar theme through this around drugs costs, CHC, but also some of our activity that is provided in England, where RTT activity is driven to a lower waiting time. So we're seeing some pressures emerging there. And that's reflected also in the Joint Committee Specialised Services portfolio as well. In terms of local issues, some of the proposals we need to go through our business case process, but we've got some ongoing pressures around revenue consequences of some of the capital schemes, diagnostics, and the GP managed practices that are coming back into our running arrangements. So there's a likely cost pressure there that we factored in. Along with that, we've got some aspirations around neonatal redesign and some digital enhancements to our service provision as well. In terms of savings, it's a very ambitious plan, but having said that, if you look at our savings level at £40 million in the plan, our route map identified 38 million, and Welsh Government expects all organisations to find a 2% CIP saving, which is 36 million. So a stretch above our intended approach is £2 million. If you reference that to the last couple of years, in 23-24, we saved £43 million, and in 24-25, we're online to achieve a £45 million saving. So whilst it is slightly above our earlier expectations, it's not out of line with recent years' delivery levels. And there's obviously pressure on, I used the phrase low-hanging fruit. I think you picked the low-hanging fruit first 3-4 years ago, but there's an issue now about making greater savings in that challenge. And obviously we need those savings to be recurrent to support our underlying position going forward. So in terms of our savings, we've got 16 million confirmed, which is an £8 million improvement on the briefing session. It's a significant positive step. Opportunities identified with a clear line of sight following our value and sustainability broad process reviews of 10 million and opportunities to be identified and confirmed at 14 million. So overall, that's 2.3%. And our processes for delivering those will be through our value and sustainability board process here, expectations on budget holders, leveraging national value and sustainability board opportunities. Also, our internal called QIA process called impact assessment process, and there's schemes that are going through that shortly. We need to optimise delivery of the enabling actions, which Hannah's referenced earlier. There is quite a drive from Welsh Government to prove we are driving that and delivering those. Benchmarking opportunities which we see through our compendium, and also realising the benefits of the investments we've made and making sure where there are savings financially that they are delivered. In terms of risks, significant risks probably is the uncertainty of our assumptions, because again, we haven't actually started the financial year yet. Although, as I said earlier, having considered some of our peers' positions, we seem reasonable in terms of our assumptions. We have anticipated income, which isn't confirmed, but we have that every year. Just to note that that part of our plan does include anticipated income, and obviously our savings identification and delivery and converting opportunities into actual financial savings is a key priority for us. In terms of a 3-year outlook, I've taken the point of revising the route map using the same sort of principles, which are looking at the reasonable level of income uplifts, holding our spending within current levels, and being taking a view that our savings over the next few years, if we achieve what we need to this year, may not deliver to the same high levels, and being pragmatic around that. That does give us a break-even outlook for the next 3 years, which matches our IMTP period, with recurrent break-even in 27-28. Again, as subject to assumptions that need to be firmed up as and when we get allocations every year, and review some of our cost pressures, especially where they are nationally driven or related to target achievement. So that's the overview of the financial elements of the plan.
Thank you. I'll just quickly add then that Rob's picked up some of the risks around delivery and finances. Obviously, there's risks to the general delivery, so there's a capital availability risk. Some of our ambitions is requiring us successfully securing capital. We know there's a big digital agenda in order to realise some of our ambitions, and we know, and we've seen it in previous years, there's always some of the unknowns that may hit us from an operational perspective in terms of issues that may impact on some of our commitments. And just finally, Chair, we'll be keen to ask questions. We set out in the plan the delivery framework, so how are we going to do this and how are we going to track us doing this? We will be continuing to use programmes to drive areas where they're cross-divisional, cross-organisational, and the performance management and accountability framework, which we recognise needs review. We start some of that as execs tomorrow, with an intent to bring that back to the board and committee colleagues. So we have a session as execs tomorrow to review our programmes for delivery, how we will track and the reporting, and similarly start the exercise on the performance management framework review, testing if we got the right meeting structure, information, escalation criteria, escalation support, actions in place. So it's referred to in the plan, but we're going to try to finalise some of that work tomorrow as execs to bring back to board. So I'll pause there.
Thank you, Hannah. On that latter point, obviously, it would be helpful to have feedback from you when determined about how the milestones will be delivered, because it's really important that the board receives information on the feasibility, cost, efficiency, effectiveness, consequences for our staff, and the populations and whether there are health gains, you know, the whole match has got to be really thoroughly reviewed because those are the sorts of questions that our population will ask and our staff, and also the government will ask those questions. And I hope we use the opportunity of almost the flexibility that a balanced, if difficult, IMTP provides to us to be really creative and very innovative in the way in which we deliver in the future. So I look forward to hearing the outcome of your discussions. I think that the presentations that we've received in the past months from the Executive Board have been very helpful to prepare the board as a whole for this sort of discussion. And it's been really useful that you've kept us very closely aligned in terms of thinking and possibilities for having a balanced IMTP, if tricky. Any questions? Paul?
Just to say well done, I think it's a terrific amount of work. What I think is pleasing is that we're at a stage where in March we're looking at this, as opposed to looking at it in July or August, when we're already several months in. What can the board do to help you and also Rob to ensure that this is delivered? I totally agree with the chair's view about creative and innovative ideas, particularly perhaps in primary care, etc. But what can we do to help achieve this?
I think, well, thank you. I think partly is keep asking because there's different questions that help us reflect and challenge us to make sure we're not in sort of a group think. I think it's as well recognising that the plan, whilst there's a lot of detail, we know things will change because we know what we know now. We know we've got more work to do on finding savings. We know we won't stop looking at opportunities to further improve performance, outturn quality improvements. There's that recognition that it provides a really important framework for our decision making. And then when we bring things forward to boards and committees in future, I think it's incumbent on us as sort of the exec team to help you how those pieces of work that come forward sit within the context of this plan, because it's all connected, it's not something separate. And hopefully you've seen that from Tracy, just helpful having that go first, because it is an important, everything we do should be connected. So sort of, you know, holding the mirror up to us on that, I think is helpful.
Yeah. Bill?
Yeah, well, quite a plan, isn't it? When you manage to get through it all. I mean, the size and scope of it is quite enormous, isn't it? And incredible amount of challenges in there, but also a lot of opportunity as well. And I think it's quite an upbeat plan in many ways because it's quite ambitious. I think clearly there will be a challenge around the money, about whether we have the capacity in the organisation to take out what we have to take out. I think would be a stretch, particularly when you look at what we've already taken out. It's not as if we started from a base and we haven't actually made savings. I mean, if you look at what we've made last year, enormous amount of money we've already taken out. So to take further money out is, I think, is going to be a real difficult job to do. I'm sure we will get some way towards it, but I think there's a risk in the organisation whether we will actually get to where we think we will get to. I think capacity generally is going to be a stretch because we're talking about changing so much and doing so many things. I think we probably have the wherewithal to do that, but again, I think it's worth saying how difficult it's going to be. I was particularly keen to see that we're prioritising place-based care now, moving from finally talking about it to actually doing it, which I think we need to welcome. And indeed, if we look at our difficulties in primary care, I think the solution to that is probably a place-based solution. So it's not just, you don't just get one kind of hit with that. I think you solve a lot of issues really. I think for the board, the next stage is making sure that this is a living document now. There's so much effort gone into it. It's not something put on the shelf and tick the box and say, well, we'll look at it again when we come to next year and year after. I think what we need to do is make sure it lives. So for us, I think it's about, well, how do we actually monitor the implementation of it, which is the key issue. And I think Hannah's presentation was particularly helpful in that, because the headings that she listed, I think, would easily flow into something of actually almost having a separate kind of or a linked but separate monitoring arrangement for this plan that maybe is linked to everything else that we do, so stand separate to it. Because this is the fundamentals of change, isn't it?
Yeah.
This is the plan that is going to change what we want to change in order for the organisation to survive, really. So I think that will be helpful. But generally, a really good piece of work in terms of where it is. The real work now is actually getting it done, isn't it? But I'm sure that there'll be lots of support around the table for that over the years, really. Onwards and upwards, I would say.
Thank you. I think we'd all endorse that, and it's monitoring and scrutinising this plan now that we need to really nail down. Ewan?
Yeah, Bill Stone, a lot of what I was going to say, it's encouraging that we've now got a balanced plan in place, but we have to reflect on the plan that this is going to be tough. I think Rob's mentioned the low-hanging fruit went a long time ago now, and although we've managed, was it 40 million roughly over the last couple of years, to achieve that and keep on achieving that is a massive task on us. This is going to be difficult. So yeah, we need to give you as much support as we can. A couple of questions I've got on it. One is obviously we have so many priorities and so many things that we're being measured on, etc., etc. But obviously some of those headline ones are those ministerial priorities. And at the moment we're forecasting that we're going to be 13 out of 18 or whatever it is. What would it actually take to meet those, given that this is going to be a period that is going to be politically sensitive, I think, when we go into those elections next year? And I think our government coming, health, everything is being measured on, or a lot of what's going to happen is going to be measured on what's coming out of the health service. What would it take us? Because we're going to have the pressure of, I'm sure when this gets to Welsh Government, the pressure of why aren't you meeting these priorities? What would it take us to actually get to that point where we are meeting? Is that something we can measure, or is that something?
When I talked about the planned care as a priority, recognising some of those, the 4 specialties where we've got a mismatch of challenges, and notwithstanding huge amounts of work, as I said, towards the end of this year, that's been benefited through non-recurrent additional monies. Whilst we would hope to benefit from some more non-recurrent additional monies, what we really want is a sustainable model. So as I touched on, and surely I haven't come in here, the teams have already started looking on. So what do sustainable plans for those challenged specialty, their own certain specialties look like, and what opportunities do we have in a suite of things, from regional planning to the SIN, the optimisation frameworks coming from the SINs, to opportunities around doing more through theatres, through the high value low complexity models. So the teams and they will come in are looking at, so what would that look like? I think some of that stuff will take us so far, but I think the census will still have a gap in terms of sustainable, and at the moment we're talking a gap to 104, which 5 years ago we wouldn't have been talking about 2 years for these standard access for these specialties. We'd be talking 26 weeks. So it's capacity gap to what standard and level of access we want. So I think setting out some of that will be important. The other sort of area where we're not delivering against those is the urgent emergency care agenda. Hence, we know we're in escalation. We know we have a suite of actions to improve. So whilst we don't deliver them, we are forecasting to improve. But that's, as we all know, a very complex system that we are not in control of. Everything from demand through to discharge date from our parts of the service. So that what will it take to deliver is that multi-agency and some sort of fundamental changes in some of our system, but we can definitely make improvements. To pop in on some of that.
I think one of the biggest frustrations is the way in which some of the non-recurrent funding comes out and how late it comes, and then the enormous pressure that places both from an operational service delivery perspective and a value for money perspective, because we are not maximising the contribution that funding sort of gives in key priorities for us. So there may come a time, I think with the sustainability plans, we're working on a bit of a blueprint, I guess, for our planned care offer, I think, for the coming year. The teams are working on it at the moment around going at risk for a sustainable solution, because it will offer better value for money. a clearer path to improved service outcomes and delivery for our patients, as well as the benefit of hitting a ministerial priority, which sometimes we agree with, sometimes we don't really. I think there may need to be a bravery around the things that we don't think adds value, and a bravery in holding the line on what we know, some of the public health conversation on the place-based care that will not deliver immediate system results for us. So I think there will be a holding of our nerve around some of this whilst we aim towards that more sustainable transformation piece, because I think it is a key challenge. Capacity is one of the biggest risks that I think we do have, particularly set in the context of operational sort of leadership experience now, post-COVID, and I see it across all of the professions as well from a service delivery perspective. So I do think that more planned investment in a targeted way aligned with our priorities will be key to that.
Okay, so is it safe to say then that we will have a plan to get to these, should we be asked for it, and if some of that money becomes available, so we can roll that out at the same time? So I can imagine there will be pushback on some of this.
There certainly will. Yeah. That's part of that.
Thanks. The other one, I guess, sorry.
Carry on.
I guess I was on the finances bit. We've already got some forecast overspend on some of the departments, I think I read. And we don't really have a reserve in place.
We have a small reserve subject to what we choose to do with the local issues. So there's a choice to be made. That was going to be my point to make, actually, around question how the board can support. I think it's around choices. Leanne's laid out quite a few there in terms of what do we select as our more top priority, shall we say? And that's a decision, for the board to make. Is a balance between the finance. It's not always finance, actually. There's a limiting factor in delivery. Quite often it's to do with the availability of skilled workforce, or infrastructure. So there's, but we're within the parameters we operate within and what we've established in the plan. There potentially will be hard choices to make, and there may be partial delivery of a target rather than full delivery. I won't quote it here specifically, but we know there are higher rated priorities, should we say, that aren't written down that we may choose to focus on for various reasons, and that might be a choice that needs to come back to the board to consider. We're not suggesting we stop anything or close anything at this point in time, but that may emerge as potentially part of the QIA process. Obviously, we're not going to do anything that causes harm, but there may be, I think I've said before, there may be a choice around where we do things as opposed to whether we do them. And it's those sort of choices, I think. And the whole point of our strategic intent, picking up on Tracy's presentation to try and invest upstream is challenged at the moment in the context of where the priorities sit and where our resources are potentially going to be directed.
It would be important for us and the board to understand as well what reserve, surplus, whatever we want to call it, whatever you've got in your back pocket kind of stuff that we've got that we can allocate, or whether or not everything comes down to a choice of if we're going to do this, then we can't do that. Yeah.
David? Oh, okay.
Alan, thanks very much again. A very detailed plan. I probably should know this fact, but when you talk in Appendix 2, it says enabling actions. They seem to be another set of targets. Is that Welsh Government sort of?
Correct. That's got.
And it's obviously some of them you said fully implement, and others you got partially implements. Some of which, the reasons may be not appropriate to us. How do you actually deal with that when dealing with Welsh Government and their?
So
I presume they've set these targets.
Yeah. So yeah, good spot. So as I said, they're introduced new this year. Not it framed in that way, enabling actions. and sort of language in the framework and from the meetings we've had since the framework came out is adopt or justify. And already there is a slight nuance to some of them, and some of them I think we in our summary appendix we grade out, because so for example implement the requirements for, I think the SOS and PIF in line with the SIN frameworks. Well, we haven't, some of those have just landed in draft, some of those haven't landed yet, they've not been signed off, so some of it we don't know yet. And I think it's helpful, the adopt or justify, because in some cases there is a bit of a local context. Another one where there's a bit of a nuance is one of the enabling actions is around delivering 5% combined rate for DNA and CNAs. We're in live conversations with NHS exec colleagues on that, and I think it's fair to say been encouraged to focus on 5% DNA rates rather than complicate matters with the CNA, because that doesn't mean that you lose a slot, which is really where this is trying to get at maximum use of resources. So there is, even within that, there is a bit of nuance, but you're right to pick up there, and myself and Rob have touched on it. The focus on these is going to be significant as we go into, so not just the outputs, the metrics, but the, how you're running your service, the inputs, these sorts of enabling actions. So we have made sure we factored the tracking of them into our performance reporting going forward to next year, and we're trying to flag them throughout the document with a little icon. But yeah, they're going to have more and more emphasis as we go through the year.
And very much will be challenged on adopt it or justify. We know that already started in the 30-day challenge.
Watch this space there.
Yes, quite.
Yeah, so just to capture some of the comments, so yeah, I think we'd all agree it is an ambitious plan, but one we think has got, the potential to be delivered with the focus we've got on there. It is a continuation of a lot of the work we've been carrying on. So this has just taken us in the direction we've been in the last few years. I think it's fair to say capacity is something we need to just sort of assess, and the session we've got tomorrow is the current delivery structures fit for purpose? Do we need to simplify them? How do we assess whether we've got the capacity right? Performance management frameworks, all of them, we not kind of start from scratch. We're trying to strengthen and build on, which I think is a better position than what we've been in. And I think as we've captured, there are still choices within that plan that we'll need to potentially come back to, whether that's some areas of investment, and there's the QAA Rob mentioned, there are choices being put forward around things we could stop where maybe considered as cost effective and there's a different way of doing things. So this is our plan, that we will need to make sure we've got those regular mechanisms to come together and report back in terms of how we're doing against those key milestones. But I think there's a huge commitment to make progress in all these areas. And some of which are business as usual in a way. That being a huge organisation, we talk about this a lot, is how to prioritise, but with such a vast organisation, you can't say we're not going to do some of these things, but it's where we put our kind of power behind a number of key areas that we really do need to make a step change on, and that's kind of what we're keen to focus on. But yeah, huge amounts of work by the teams, and really appreciate to get it to this point. It's been a huge effort. It's quite a very challenging period as well, as I mentioned earlier.
Thank you. Are there any further comments? Can I thank the executive very much indeed for getting us to this point, and for keeping us thoroughly apprised of the movements in the development of the IMCP over the past 3 months. It has been really helpful, because I think we have had a collective agreement of the direction of travel, the difficulties that this sort of plan and this environment is going to challenge us with. But I think that has enabled the whole of the board to unite behind a sense of direction and purpose and what we're trying to do. This is the board's plan, and once we adopt it, both Nicola and I will be held to account for delivering it. So I think the rigour in the evaluation of what's working and what's not cannot be overlooked. We're going to have to put a lot of effort into enabling people to deliver on this plan and making decisions if our alternatives are not going to work, to enable us to keep on track, to be able to use our skills and thoughts and ideas to actually develop, you know, have space to develop new types of service to better meet the population, to take forward Tracy's planned schemes and to really take a step forward. So it is ambitious. I think it, however, it's based on realism. It's not false hopes. Things can get in the way, and as long as we have got to rigorously monitor this so that we can take swift, informed decisions for change if that is going to be necessary. But on that basis, are you happy to adopt this IMTP?
Yeah.
And thank you all very much indeed for the effort that's been put into this very difficult job and for keeping us so well informed throughout the process. Thanks ever so much. Can we move it? Does anybody want a cup of tea? Do you want 2 minutes break for a cup of, to get yourself a cup of tea?
Yeah, good idea.
Yeah, oh, thank you. Okay. Well, don't all rush at once. Can we start on budget setting proposals, please, Rob?
So, aligned to the financial plan and our processes, the board's required to establish budgets before the start of the financial year. And that budget setting's got to be within the available funding and aligned with annual plan aims and objectives. So for 25-26, as we've just discussed, that's a break-even plan, and that's based on a funding envelope of 1.85 billion. So that 1.85 billion are the resources we have available for spending for us to set budgets within. So the proposal is to take a two-part approach, as we did for 24-25. And phase one will be, or is proposed to be, based on setting budgets to delegated budget holders on the basis of ledger rollover recurrent budgets. And that will give everybody, to delegate budget holder, a budget to work on initially. And as part of phase two and during quarter one, we'll finalise budgets, and they'll be set with consideration of delegate budgets to align with the savings expected and where we expect those savings to be coming from to achieve financial balance. So part of the two-phase process is to make sure all delegated budget holders have a budget to operate within, certainly within quarter one and for most of the year, but that will be adjusted then as part of phase two. And part of the timing required between phase one and phase two is for clarity, as I say, on the likely achievement of savings, the aspirations of where we feel costs could be mitigated. And we need to spend further work to identify where some of those savings aren't yet identified in the financial plan to land them in a budget plan. So that would be phase two. Just to note that some income is anticipated. Approximately 63 million is based on anticipated income we get every year but isn't recurrent. And 14 million is a little more risky in terms of the assumptions we've made in the financial plan. But those assumptions are being presented to Welsh Government as part of our scrutiny meetings. So phase one, we will delegate 1.808 billion and hold a reserve of 44.2 million. And subject to any additional funding coming through above our anticipated levels, that reserve would be what we would use then to delegate out to budget holders to finalise phase two budget setting at the end of quarter one. Get approval of the board from the board at that point. Progress the full delegated candidates.
Thank you, Rob.
Okay.
Are there any questions to Rob? No, are we content with the way in which this allocation is going to be managed, has been presented together with the phase two end in a quarter? Yep. Okay, thank you.
Thank you.
And the capital programme, Hannah.
Thanks, Chair. So the capital programme is a key enabler for the plan we've just approved. It's key to help us support management of risks in year and the start of the year, and to push forward some of our strategic objectives. Just to remind colleagues, the capital programme is made up of two key components. So it's the discretionary capital, which is the amount of money Welsh Government gives us to determine ourselves how to spend and how and it's predominantly should be focused on statutory maintenance and management of risk. And then there's the money we get for major projects, which is on the back of business cases, and we get all Wales capital monies. So one is sort of set and one is dependent on our success in securing the additionality. So the paper before you just sets a bit of progress where we are with this year in 24-25 and seeks support for an opening programme for 25-26. So in terms of this year, 24-25, we've made significant progress. We benefited from just under 68 million of capital investment, which is significant. You know, if you compare that to other organisations and health boards as well. So we've really benefited from that investment. Sorts of areas we've delivered in is the T Gwent development, enabling us to sort of rationalise leases and make a really great facility for many teams to be based. 2 health and wellbeing centres are completed this year in Tredegar and Newport. And again, in line with some of our previous conversations, important now we sort of drive the benefits through those and make sure we're taking some lessons learned forward to any other projects. We've acquired the lease of the PFI in Chepstow. We've also made really good progress, and that's where a lot of that spend has gone in terms of some of the projects that will complete next year. So ED extension, we've touched on the radiotherapy unit and the transfer lounge as well. So paper just draws that to attention. Also sets out some of the benefits we've had from from end of year funding. So we've had significant investment into our backlog maintenance. We'll know whilst we've got some great bits of estate, we've got some real challenged areas as well. So we had a significant amount of investment towards the latter half of this year, and also benefited from investment into digital and diagnostics from Welsh Government colleagues. We were also successful in attracting investment to go into next year's plan for the All Wales programme. So this board has previously approved the BJC, the business case for the decontamination unit at the Royal Gwent, which has started, but sort of starts in earnest next year. So the attraction of this additional monies has enabled us to support services and departments in managing a number of key service infrastructure and estate risks towards the end of the year, which is why in the last few years we've approved the capital programme for the following year in January. But because we were making such good use of end of year opportunities, we see where that landed and bring it today for approval as we start the next financial year next week. So in terms of next year then, our open and discretionary programme, so our allocation for discretionary has gone up to just under 12.9 million. This is a 4 million increase compared to last year, which is really welcomed. The outline plan for next year is made up of a number of key areas, many of which are set, and then the remainder we have made some choices and propositions again. So there are bring forward commitments from this year. There are brokerage arrangements in terms of slippage on any All Wales projects for this year. There's statutory allocations in terms of the management of risk, and that's around estate and issues associated with fire, etc. We've made sure we put an allowance in for digital, recognising that is capital thirsty area. We know we've got lots of investment required and risks there. The opening programme is also made up of our contribution to the Targeted Estates Fund. I will come back to that in a moment because that's a new fund for this year that is Welsh Government fund but requires some match funding. And then the remainder of the allocation, the remainder of the plan sets out how we're going to support the highest risks within divisions. So predominantly in the place of sort of equipment, replacement, bits of kit, and a number of estate priorities as well. There are some high value items in there I need to just draw attention to, the Symphony upgrade and the plan around anti-ligature and mental health wards. So just in the context of that opening plan for discretionary, I've mentioned the Targeted Estates Fund. This, for those of you who have been close to this before, this replaces what we had before as the EFAB fund. I can't remember what that acronym stands for, but this is the targeted fund set up by Welsh Government this year to recognise some of the challenges in estate that support the health and safety agenda, the decarbonisation agenda, fire and safety, etc. And they've announced 40 million across Wales over 2 years. So we put in a very comprehensive and ambitious ask against that plan to try and again build on the success of attracting investment. At the time of the plan coming before you, we had to make assumptions that all of it would be funded, and therefore The requirement is that Welsh Government will fund 70% of the ask that they agree, and then through our discretionary programmes, we're required to match the 30%. So the plan before you assumes that we would have had all of our ask, and therefore we'd have had to put 3.7 million of our discretionary, and that was the sort of safest assumption. We've since this paper was finalised, had confirmation of our allocation. So against 40 million across Wales, we've been successful in being given just under 12.5 million. So that's quite significant against 40 million for Wales over 2 years. That means that does sort of adjust the figure in the plan from the 3.7 TEF contribution down to just under 2.9. So what that means when you work through the bring forwards, the statutory allocations, the service priorities and the TEF contribution that which we're seeking support for, we will have an uncommitted value in the discretionary programme now just over 1.6 million. So just under £1 million above that in the paper due to that TEF confirmation we've had. I personally am comfortable with the uncommitted at the start of the year, recognising a number of still unknowns. There will be a national imaging programme that we've still got to understand some of the detail, and that may impact and influence how we choose to deploy the remaining unallocated. Still waiting, unless something's come in recently, the clarity on what the national informatics and the DPIF money will be. And we do know, and we've touched on it previously, that there's work happening in a number of areas that will influence where we may want to deploy some of that capital, not least there's work in mental health on models of care, and there's work in the space of the RPB in terms of reviewing assets and reviewing the RPB capital and estates plan. And not least, we've committed to reviewing and updating our estate strategy. Keeping some of the unallocated, just unallocating a proportion seems sensible, recognising we've still got that work to do. So the first part of the paper, the first part of the ask is to approve that initial and opening programme for the discretionary contributions in line with the appendices set out. The paper then does just go to set out what's in our capital plan from an all Wales capital funding perspective. That currently sits at just under 12.2 million, and that's made up of the investment that we've already secured through previous business cases. So it's predominantly around the final stages of the radiotherapy unit, the ED extension, the decon scheme I've touched on already, ongoing demolition and some fees for some of the primary care estate solutions that are being worked through. And then just finally, before we pause for questions, to note that in terms of business cases to access all Wales capital money that we can expect to bring through over the next year in line with the plan is the SOC around Neville Hall, a plan around St Willis that has lots of work's been done over this year in terms of the enabling using some of the backlog maintenance monies I touched on, and business cases for the wellbeing centres in Abervalley and Monmouth. And all of that work obviously is in the context of, as I said, the update real estate strategy that we've got planned for early next year in line with where the organisational strategy lands, where the RPB work lands, the mental health models as well. So I would ask the board to commend that as an opening programme, recognising that we have some opportunities in the unallocated amount as we go through and some of those issues emerge, and opportunities to access more Welsh Government funding when clarity on those bespoke programmes of work becomes clear as well. Happy to take any questions.
Thank you, Hannah. That was very clear. Are there any questions to Hannah?
Just and you mentioned at the end there the estate strategy obviously coming next year, because it's obviously very difficult to reconcile this to what our estate strategy is without that estate strategy. So maybe it's something we should revisit then when that estate strategy comes out and go, yeah, this all of these things make sense, obviously. But once we get that estate strategy, then it's the
prioritisation, and we're against that.
Yeah, absolutely. And just to give the board assurance, even in the areas where, you know, the discretionary programme is not exclusively, but predominantly focused on a lot of risk management, as I said, equipment, bits of digital investment, but there is some sort of estate, you know, in terms of award replacement programme, the anti-ligature work in mental health and LD. Throughout all of that, we will test and challenge in terms of, do we know anything new now? Is this going to be abortive work, balancing risk versus risk of what the issues we're trying to resolve? But if we know anything new in terms of direction of travel on estate, so we will sort of commit to keep doing that. So we're not, for example, which we wouldn't be doing, but like doing up wards in St Woolas that we're about to close in a few
Yeah,
months.
that's what I mean about it. I mean, all of this stuff makes sense, but you can't tell what it means in terms of that 10-year plan or
The
whatever.
big strategic pieces in terms of which we know will to bring back to a future development in the session in terms of Neville Hall, St Woolas will still feature. We know they're going to feature in our estates strategy going forward. So, but yeah, we'll commit to doing that and keep doing that sense check.
Yeah, so it's just builds on Ewan's point, because I know we've talked about getting that kind of the new 10-year outlook, so we all kind of got that vision. But I think in the absence of that, we have got an existing estate strategy. Whether we think it's good enough is a separate discussion, isn't it? But in there, this is consistent with what we said, which was the St Willows trying to get that old part of the estate, the ELGHs and Neville Hall and some of those primary care developments. So it's consistent with what we said 6 years ago with some of the, but I appreciate it doesn't then set out, which is that what we need to do now following the main strategy, which I think will help us kind of have that vision from where this fits into the next 10 years. But, you know, as much as I know we've all got issues with the current one, there is one there that this is consistent with the knock-on off piece. But it's just taken so long to get us to this point, like St Willows, for example, has been an ongoing priority for us for some time, isn't it? And really important to get that one. Yeah. Over the line. If you're going to possibly Neville Hall as a new, there's a different priority.
Well, yeah, Bill?
Yeah, it's just an observation more than a question really on reading the report. Nothing in that I would disagree with, but I just wondered at times whether we get the balance right between the new and the old. I used to work for somebody once who was an ex-naval admiral. He used to say, well, it's okay launching new ships, but remember you have to keep the fleet afloat. And I just wonder at times whether we need to be thinking a bit more about what we've got and invested in what we've got, as well as thinking about, I know a lot of these funding streams are predetermined on the outside. You've got to do a business case for a new build is probably much easier than a business case for a new roof. But I just wonder whether, because of our lack of looking after the rest of the fleet over the years, for obvious reasons, we get ourselves in a position where things are falling down, and we need to replace, whereas if we'd invested properly over the years, we wouldn't perhaps be as, in some areas, as bad as we are now. And that's not just us, I think that's the whole public sector.
Yeah. Can I come in? I think we've had conversations, we've referred a few times today about the session we've had and the sort of intent now around the place-based care work. And I think we've got to a place, we've launched 2 new health and wellbeing centres. They're magnificent and they're big buildings, and I think we're on the same page in terms of, like, let's let them bed down, see how the models work. And there's a view emerging, I think it's fair to say, well, from the divisions, is we probably don't need any more of those, or we don't think we need any more of those yet, because 1, we need to see the benefits drive through, and 2, we need to recognise it's not always about new and shiny. There's a challenge to how we look at all of our collective assets. And the work, it's been tricky, and I'm sure we'll come back to it at future boards in terms of where it lands. But some of the work we're doing on the Aber Valley and Monmouth are much smaller. It's much smaller projects than the 19 Hills and the Bevan, sort of taking some of the learning, but recognising some of the sort of immediate estate challenges there. But I agree, we need to be looking at what we've got, not just us, but with partners as well, rather than always something new build and new. However, recognising there's a sort of nuance with Neville Hall where, you know, we really do need something new built, but challenge ourselves on the models that are.
Yeah. I mean, a couple of new scanners, for example, might be a far better investment than, you know, a huge shiny building somewhere. You're just getting that balance in one.
Agree.
So I just mentioned about the creative and innovative approach really. You've talked about earlier on the health and wellbeing centres, but I think there's opportunities there that sort of invest in at the partnership model, which is with local authorities, with the voluntary sector, which gives them opportunities to join us for various things. And it hasn't got to be the big shiny building. You could have one building which offers, for example, pop-up shop sort of opportunity for different groups to come in to be able to do things. So I think it's just having that conversation and probably with the community to say, okay, what do you need? Because something in Monmouth town centre may not be the same as up in the valleys up in Aber Valley, for example. So I think it's not one size fits all. And that's probably the only thing I'd push back on and say, let's not say we should do it because one doesn't work as well as the other, but to have the conversations with the local population to think, actually, this would work here. And I think probably to get Tracy's input as well, with conversations from the chief executives about the demands on the schools, the population, the groups. Right, it is a really exciting opportunity that we should utilise really.
Yeah, I don't disagree, and it's important we get an opening position in order to enable us to support some of the risks. But in terms of some of those big strategic things, with a number of the areas we've talked about today, we can expect us to have more come back in terms of the intent there in the RPB space and PSB. You know, so Tracy and Leanne and her team, there's quite a live conversation on I think something similar to what you're saying, bringing the place-based and the pop-up model. But there's a Gwent House project emerging in terms of working together with third sector on a high street as an opportunity there. It's not a new build. So some of that stuff still needs to be fully sort of worked up and worked through. But I think it's a fair challenge, which we're
Are we happy to adopt this proposed opening programme then?
Yeah.
Yeah, thank you. You again, Hannah, regional planning and the strategic vision for Llantryston Health Park.
Okay, thank you. So I'll give a bit of a brief overview, and I'm sure Nicola may want to come in before opening it up. So the board will be aware of work taking place under the South East Wales regional structure. And indeed, I think both Chair and Chief Exec noticed it in their respective updates. And we do put regular updates through to the Population Health Planning Partnerships Committee, and we had a recent board development session on it. So one element of the regional work, which is the sort of organogram is set out in the cover paper, but one element of the regional work is the Llantryston Health Park development, which and the need for the region to consider the opportunity that it offers in addressing some of the capacity challenges that we have, particularly around elective care. Recently, through a number of conversations, again, that have been touched on, so Julie Paget, the DG of the Director General of Health Department and Chief Exec of NHS Wales, recently wrote to Nicola and her colleagues in the three health boards in the region, asking for an update on a number of key issues relating to Llantryston Health Park and regional planning. And one of those, kind of the key sort of product in that request for information, was around a bit of an overview document on what Llantryston Health Park is all about and what opportunity can it offer the region. So the paper sets out from a health board perspective the background, intent and opportunity that it offers AB, and there is a paper then developed by the Llantryston Health Park project that seeks to respond to the request from Judith Paget. So I think for us, from a regional perspective, I think it's fair to say we'll just test the position with the board is that, so it's a facility that was purchased by CTM Health Board back in February through Welsh Government monies, the All Wales Capital money I referred to earlier. The site is close to the Royal Glamorgan, so it's separate to the main hospital building, but close to it in terms of all the sort of access issues and opportunities that arise from that. And it is of a size that could accommodate a range of elective services. From a regional perspective, the programme, and I think the respective boards have been clear that it is a CTM facility, as purchased by them through that money, but it does offer some opportunities to the region in the context of the regional agenda that we've been taking forward, which, as you all know from previous updates, is around diagnostics, orthopaedics and ophthalmology, although we're not talking about ophthalmology in this context. So the paper sets out some of this, and some of the key points I just wanted to draw out is in terms of the service profile for Llantriston Health Park. The current plan is that it will be for CTM. They will be realigning or reproviding some of their day case activity. So that's sort of a CTM only element. It will also provide radiology, so CT, MR, etc. for CTM populations. So again, that will be a CTM specific element of the proposal. And then the other service elements of the proposal is where there is an opportunity for regional capacity. And then being endoscopy, which again, the thinking is that Llantriston Health Park will reprovide some of CTM current activity and now some of Cardiff and Vale's current screening activity. But then over and above that, it will offer some additional capacity to support a projected capacity gap across the region, including it will be the home for an endoscopy training academy to support the development of workforce in this quite sort of niche area of service. And then the final element that would be that offers a regional opportunity is around orthopaedics, in terms of orthopaedic capacity for high volume, low complexity services. So the purpose at this point is just to try to set out the vision for that facility, CTM owned, some CTM specific facilities, but with some regional opportunities in those areas I've just outlined. And the board at this stage has been asked to sort of note that as a strategic direction of travel and support it, recognising that on the specific areas where AB may want to consider and the region may want to consider an interest and an opportunity in, they will come forward in separate business cases demonstrating the case for change in terms of demand and capacity, how it links with our current plans and ambition around existing facilities and estate, and that's true for endoscopy and orthopaedics. The paper, I'll just finally say, the paper does set out that we've been engaging as a health board and obviously in all the regional work, and have been setting out our position through the use of some position statements and how the opportunities of LHP links with our ambition around maximising our existing infrastructure and state, and ensuring that we sort of drive both best efficiency and productivity through those services and resources before we start considering additionality. And a key principle for us, and I think we've heard this from the board as well, is when those business cases come forward for consideration, that they all have to sort of stack up from a value for money perspective. And then finally, just to say, there's to be recognised that from our perspective, if we support these cases, that would be additionality. So we would have to be seeking a revenue funding to support those, but those need to be considered on a case by case basis. So Nicola, did you want to add anything before? There's quite a live conversation at the moment in the regional space, as touched on in your update.
Well, you've covered most things. I think it is just important to reinforce there is a kind of high expectations about us working on a regional footprint where there is a strong case for that to happen and be able to deliver improvements in throughput, productivity, efficiency, and this is seen as an opportunity to do that in the areas we've set out, and particularly endoscopy and orthopaedics and areas we've got kind of the most interest in that. So I kind of just reinforcing the expectation. It is a significant capital investment for the region. And I think, as Hannah mentioned, what we are keen to do is make sure any decisions we take are tested around making sure that is tested as productivity and efficiency to local choices. And for example, endoscopy, which we're hoping to bring the case fairly soon on, because it's almost almost there, we would look to make sure we maximise our existing endoscopy facilities before we'd seek additionality on the basis we believe that demonstrated value for money. But we obviously need to tease that out as part of the case. So in all the areas as a region we've identified could benefit from the site, which offers CTM more local opportunities as well, as Hannah said. But keen to work with partners across the region to make sure we, further explore these areas, and especially in areas where we know we've got long-standing demand capacity shortfalls, such as orthopaedics. So yeah, that's what I was going to add. But there is I can't underestimate the kind of expectations around us, making sure we work together to demonstrate how best we utilise these types of facilities. Thank you.
Oh, I mean, it's interesting what you said, which is incredibly helpful. That it's because I noted down, and I've got 4 points that I wanted to raise. One was that to maximise and optimise the current existing work that we're undertaking, so we need to find out what that's all about to start with. Imaging was going to be CTM, endoscopy I think was CTM's Cardiff and the Vale and potentially us, and then orthopaedic, the area there, but it is a CTM facility, and the multimodality day surgery really was a consolidation for them, which I think is good. For me, it'd be interesting to see the full business case, and in particular the revenue costs. And I think what would be useful would be to see whether, because I think in principle it sounds a really good idea, and I think that there's some value in it, but it's about whether there's some options in terms of, okay, well, we need more endoscopy, so could we look at that? And when I read on the page, back not to be on site in November 2025, I did think to myself, well, that's interesting because we haven't yet seen a business case. So I think it's worthwhile, just sort of seeking some further clarification. But I think it's always good to work together on projects. But sometimes, and it's really, I think, really helpful for CTM particularly, that they're leading on some of the areas, and because obviously it's local to their members of their community. From our perspective, we have to factor in the sort of travel arrangements as well. So I think it's, when do you think the full business case might be ready then, if they're going to have the contractors in on November?
I think we just have to, we had a regional meeting yesterday, and Rob was there, and say it was really clear exactly when it would be ready.
The conversations around governance processes, documentation, regional approach, three-way sign-off, etc., a little bit opaque at this point in time.
Okay, that's helpful.
So we'll keep, there's definitely CTM really want to obviously deliver on those milestones, so it will be working to see how to hit a November milestone when a decision, I think there's lots of dates in the paper. I think it's a September board's planning to bring that full business case for the complete capital ask. But I think from our perspective, and we'll need to review it and consider it when it comes forward, is that that'll be a significant capital investment for Wales. So if it's been spent in one place, it's
revenue. It's a revenue cost, I think, is the area that I think we worthwhile just exploring as to whether there may be some additionality money or additional money available to cover that, because that could be quite cost driven.
So discussion yesterday was around that point to a degree around understanding if there is any potential funding, because obviously, given the conversation we've had earlier, this is helping us achieve targets, but we've got to balance that with the resources we have available. At this point in time, the line of sight for the additional activity isn't in our plans anyway. We'll probably be sat in another IMTP round discussing the step up if we want to engage with this. It's not an absolutely clear picture around, are we commissioning services or are we a partner? It would be clearer and cleaner if we were commissioning services, but that needs to work up as part of the case.
That was the option I was referring to, I think. Yeah, thank you.
Thank you. Are there any further comments or questions?
Yeah,
Bill?
good, Chair. I think it's good to see this. I mean, it could be a good project, and I think when you look at the population base of Wales, I mean, undoubtedly we will need to move to probably more regional models in the future. On the downside of this, I guess we weren't at the main table right at the start of this. We kind of joined the party a little bit later. I don't say that as a criticism, because often these new ideas have to start somewhere, don't they? Often you can't engage everybody at the beginning, so you have to hope that other people will join. But in that sense, there are a lot of unanswered questions in this so far. We've got some good ideas, good principles, but the detail of them, and the devil will be in the detail of this, and we're probably too early to get to that kind of stuff. But I mean, if we were looking perhaps for a message from the board, I would say that we would support this with an amber light. And I think what the Highway Code said about amber is proceed with caution. And I guess that would be the message that I would be giving if Welsh Government need a message from us. That's the one that I would give, that it is not a green light, it's not a red light, but it's an amber one. But we do need to see the result of a lot more discussion.
Yeah.
Great.
Anything further? Can I then sum up basically that obviously it will be for the partners to decide what level of service they need from Llyn Tristram's Health Park. We know that the plans could offer a significant opportunity for the region, because we've done the work to show that, you know, there's going to be an escalation of demand, and we need the capacity to enable that demand to be accommodated. We really need to see, in the context of this proposal, what does the Ministerial Advisory Group on Productivity and Performance recommend? Because certainly when they were with us, they very much pushed the point that we have to maximise our own facilities. But all of this requires additional revenue to do anyway. So this could be a helpful solution to some of our future demand. It does offer support for those challenges and could allow for the consolidation of services where this would add value to the health board's populations. That's all three of us, not just one, bearing in mind that we have to maximise our own facilities and they could also be offered elsewhere. So I think that we note this with an amber light, and that we await receipt of the business cases and the assumptions in respect of proposed developments to enable further consideration to be given. So it's a sort of in principle, yeah, amber, but we need to see the detail case by case. We've got to see the detail. Would you be content with that?
Yeah.
Okay. Thank you. Digital failure of pathology.
This paper is requesting approval of the National Business Justification Case to digitise the Health Board Cellular Pathology Service, and as you're aware, we had a recent board briefing on this topic. Just to remind the board, currently the cellular pathology services uses traditional slides and staining techniques, which are then viewed under a microscope by a pathologist. It's a really essential service for the Health Board to diagnose medical conditions and also to ensure appropriate treatment. So there's an ambition to digitise this service across the whole of the NHS in Wales. So then the slides are actually scanned using some of the latest technology, and then those scans are viewable by a pathologist using digital software and equipment. There's a number of drivers why this digitisation is really important. So the first one is staffing. So the current specialists currently being trained in cellular pathology are being trained in digital solutions rather than the old way of working. Without this digital solution, we would fall behind the rest of the UK in the use of this technology. and ultimately that would lead to significant challenges in recruitment in an already challenging space. There's also advantages with demand and capacity, so there's obviously a growth in future demand for these services, and obviously there's still a backlog following the pandemic. And also this really does improve productivity and efficiency of digital cellular pathology services. And finally then is how it helps modernise services going forward. So it supports remote diagnosis and consultation, and it also becomes a key enabler for regional working. So the approach to this project is that national governance is being provided through the NHS Executive and the National Pathology Programme, and also then through the NHS Wales Shared Services Partnership will run the procurement. Incremental work has already been undertaken across Wales to provide some digital scanning and some artificial intelligence pilots in some of the services. And a prior information notice was issued to the marketplace in April 22, and 7 suppliers responded. Then the costs were refreshed in the business case in November 23. So the proposal is the procurement process will run from April 25 to March 26, and then a phased implementation from April 26 to March 27. So the business case is actually seeking a full revenue commitment from the Health Board for the associated system, equipment and staffing costs. There is no national funding currently for this. Costs are provided on a worst case scenario, and obviously those costs will be ratified via the procurement process. This has been reviewed by the Health Board's pre-investment panel, and we've passed comments back to the national programme. That's also been reviewed by the Executive Committee, and also the board we recently had. You should note that the do-nothing approach introduces a number of risks. So obviously the sustainability of the service going forward would be put at risk. The current scanners we've got in the organisation are out of support in 2026. We'd be unable to realise some of the opportunities of artificial intelligence going forward. As I already mentioned, we would be left behind with the rest of the NHS Wales as they adopt this solution. So the business case outlines some of the national benefits associated with this. So it's obviously to provide a modern and sustainable service, the use of AI, as I've already mentioned, the increased efficiency and accuracy in reporting. There are significant reduction in turnaround times, and report from any location and device. The service would be delivered via a modern cloud service, hence why it's traditionally revenue focused. Supports the recruitment and retention of cellular pathology staff, and also it improves the general infrastructure of the pathology service. So working with the division, we've also looked at some of the specific Health Board benefits that we can get around this. So one is around regional working. So obviously it would be a key enabler for a potentially unified pathology services in the future, and also gives us the opportunity to optimise our regional clinical resources and support those care pathways across organisational boundaries. We've done some work on the safety and efficiency that this solution would bring. So there would be a reduction in repeat tissue sampling, because less samples would be lost, damaged or misfiled. It would bring some workforce efficiencies in the laboratory. There's time saved in managing slide transportation and delivery, for example. And then obviously those digital images support the option of having second opinions, because the images can be viewed from any location. And there are some financial benefits which I'll outline shortly. And then around sustainability, supports recruitment and retention of consultants, supports modern training programmes that are currently underway, and there is a reduction in workforce travel and supporting that flexible working approach. So from a financial perspective, there aren't a huge amount of cash release and savings from this. The paper outlines that total of around £85,860 a year, and that is just around reduction in postage cost, reduction in cost for storage, reduction in expenditure on microscopes. So there are some cash release in savings. The paper then also outlines the cash release and savings of just over £263,000 a year. And the majority of these cash release and savings are reduction in workforce time spent in managing the traditional slides, and also reduction in time spent peer reviewing is another significant non-cash releasing saving. The paper then outlines the financial summary over the life of this contract. So the total costs are £5.7 million. The total cash releasing savings are £712,000, leaving then that net cost the health board of £4.9 million. When you take into account the non-cash releasing savings, that's totals £2.1 million over the life of the contract. So then the net cost of the health board then becomes £2.8 million. There is some local investment required in capital equipment in 25-26, which is around £72,000. That's just improving some of the network connectivity required to support this programme. So the board is asked to approve the national business case, and just note that the national programme will procure with this new solution in 25-26. And then obviously the health board will support the implementation activities to undertake this, and would re-baseline the benefits once the chosen supplier is anticipated. Should note clearly this is not a significant, it's not an insignificant ask from a financial perspective, but I hope the business case and the paper outlines that the do nothing approach is really not going to help us sustain these pathology services going forward. Any questions?
David?
I think, but for me, this is an absolute no-brainer. We've got to do it. I'm absolutely sold on the benefits for it. I'm absolutely sold on the fact that if we don't do this, we have the risk of a serious collapse in our ability to deliver services. The figures in the business case are really clear. So something like 90% of all primary care referrals require pathology, or 75% of all diagnoses in hospital require pathology. If we don't do something to maintain those services, then we are going to find that our ability to offer healthcare is going to substantially decrease or become problematic. And we're already spending a significant amount on outsourcing each year for pathology as well. I think business case mentioned something like £600,000 a year on outsourcing, and that will only increase if we can't recruit. So I'm absolutely sold on the benefits of this. I think I'm a little bit disappointed that business case doesn't take some of that stuff into account. This business case feels like we're spending a lot of money and getting a small amount of benefit from it, whereas actually the real benefit comes from the fact that our service isn't going to collapse if we don't do this. And the business case, while it says that in the narrative, doesn't come out in the financial case, and I'm a bit disappointed that we haven't got that, because I think it'd be really helpful to help maybe to show that this is an important case and why we need to do it. It's a shame that it hasn't got that in there. I think there's a couple of other things I wanted to call out. One of which is, obviously, we don't have the procurement hasn't happened yet, so we don't have a supplier. We don't know what the technical solution is going to be, and we don't know what the implementation plan is going to be until that procurement is done. So there's a lot of assumptions in this that we don't know are certain, and until we've got those, it's a bit hard to know what's going to happen. And in a lot of these national programs and a lot of these big technology procurements, the procurement, the implementation plan is where the wheels tend to fall off and things tend to go wrong. And so I think I would be very keen that the board gets regular updates throughout this process, so we know what's going on and have the ability to scrutinise and challenge, particularly to scrutinise what's going on in NHS Wales, SSP and NHS Executive as they're making some of the decisions around that, because that could come back and have a big impact on us as we go along. The final thing, and just this is a thing that's worth noting, is this is a big revenue cost for us. I think that needs to be dealt with at national level, hasn't yet been dealt with either in UK government or in Welsh government level. This is the reality of moving to modern technology. is that it more often is a move towards revenue-based revenue funding and ongoing revenue funding rather than capital investment. And the financial systems and the financial models that the UK public sector uses for this has not caught up with the fact that the world's moved on. And as a result, our revenue costs are going to increase every time we do a digital transformation, every time we change something. But it's not recognised in either the way the UK Treasury manages their Green Book or the way that then trickles down into Welsh Government and into our finances. So this is going to be an ongoing pressure for us. But so for me, this is really important. We've got to get it done. There's a lot of unknowns that I'm quite nervous about. But I think if we don't do it, we've got a bigger problem coming up.
Thank you. Ewan?
Yeah, just to echo some of that, I think this is an incredibly disappointing business case. I think as a business case, it doesn't stack up. If you just read the business case, it says do nothing, because there are so many costs that are going to come out of this and so many benefits. I think you have to read between the lines to see where the benefits are or why we have to do this project. But the business case says do nothing. If you don't do nothing, do the minimum. And it's incredibly disappointing. But yeah, I mean, I echo everything else that David said, and you know, in fact, this is possibly the only business case I've seen where AI is coming into something and it seems to cost you more and more and more, rather than look at what you're avoiding in terms of cost and everything else. The only thing I'd add on, I guess, is that this is going to cost us 600 grand a year. We just had the discussion on the IMTP and finances around we're short of cash. So this comes down to what are we not going to do by the sound of it. So there is a decision there that needs to be added on to this business case of where's the cash coming from.
Yeah, just to come back on that, I think this business case has been in development for quite a number of years nationally, and I have seen a change. You know, some of the feedback, you know, you've given David on previous cases. There is now an exception that whenever there's a national business case, you have to have a local case that's taken through your own governance processes, your own benefits, looking at the benefits of the wider case, which will then supplement that national case in a similar way what we did with electronic prescribing. I think there's an acknowledgement nationally now that that's the way national business cases need to work in the future, and I think that's a key thing. And on the funding, the Audit Wales are about to initiate a national audit into digital across NHS Wales, and there's a real opportunity for them to shine a light on some of the funding challenges that we've got going forward.
Yeah. Yeah, so thank you for your comments, and I think buying the impact of doing nothing in what you're saying is to be potentially quite powerful. I think just on the funding point as well, you know, linked to our IMTP, you know, I think some of these big national digital programs, depending on the revenue uplifts we have going forward, we would, you know, we will be feeding back that we would be looking for support for, and that's one of the assumptions we've got in this year's case, where we've got a couple of national digital schemes with an uplift of 1.77%, you know, is a huge challenge for us. So, you know, we will be putting forward case to see if there is, because there has been opportunities previously through the what was known as the DPIP fund, and you know, if these are big national priorities for us, then taking a kind of a support fund funding some of those where opportunities exist nationally, then that would be hugely welcome. So we'll continue to push on that basis, recognising if the answer is no, then it is left with us to pick up, as you say. But
yeah, just one more comment on the benefits. We'll be doing reform that benefits framework shortly, and we're developing a benefits dashboard. So the intention is to take the digital benefits that we're realising through the value and sustainability structure, just to provide that assurance and reporting to the board.
Are there any further comments? I can conclude then from the observations that have been made is that we agree in principle the case for digital cellular pathology, and it's perfectly obvious that actually we can't not do it, as both Ewan and David have said. We're very concerned indeed about how the additional revenue costs are being covered, not just for this scheme, but why they're not brought into consideration for all the national schemes. and we expect you all obviously to follow that up. I don't understand why reducing analysis time actually doesn't release money, and perhaps we can have a note on that because I don't understand that. Nevertheless, the principle of this this development is undeniable. But I think we need to go back, as Nicola has suggested, to say, what about the revenue costs, bearing in mind that we have a very, very, very tight IMTP from which to fund anything, and other health boards have an even greater problem. So this will be a problem that's affecting everybody. And would you be happy on that basis to approve it? And we'll come back about the resource. Yeah.
Yeah, so the only other thing is I'd really like to get regular updates and ability to scrutinise the steps as they go along. In terms of approving his business case, I think is fine, but there's going to be a point where there's going to be a contract award, there's going to be design of implementation plans, and on all of these national programs, that's where things have gone wrong.
That's true.
And so I think I would appreciate us having the opportunity to do further scrutiny along the way.
Yeah, I think it's probably because there's a number of big national projects ongoing now, isn't there? I think maybe linking with Paula and do a quarterly update, and then think about the best place to take that, but the opportunity for discussion.
There is a paper that goes to every finance and boards committee meeting as well, so we could build it into that.
Yeah. I'm just conscious
of them all in one place as well, then, because
I think part I'm just conscious that this is where these things tend to go wrong and are continuing to go wrong. And given again it's a national programme, there's a lot of heavy reliance on delivery from NHS Wales SP in this case. I want to make sure that we have the ability and the levers to effect the changes needed when things start to go wrong.
Yeah. It might get right, you never know.
And if it does, I will be very happy if it goes right. It would be very nice if this one goes right.
Thank you. Okay, that's approved then with those caveats. Thank you. The strategic equality plan.
Thank you, Chair. So this time last year at board we agreed a refreshed strategic equality plan in accordance with our obligations under our public sector equality duty. And the paper today brings a one-year update in terms of the actions and priorities that were agreed as part of that plan. The plan was agreed with 3 themes, so patients, people and population. And we're just very recognising within the update that the actions across those themes overlap. And we also recognise the intersectionality between the protected characteristics. And so the outline paper considers the updates against the various protected characteristics and some key highlights. And it's by all means not all-encompassing in terms of the great work that's undertaken. The paper has also been written by our Equality, Diversity and Inclusion team, but with input from the services and teams which are undertaking this work across the health board. And we've already seen an example of that this morning in the patient stories. There's been an opportunity for different groups to feed into the update. Within our priorities agreed as part of the plan, there were 59 in total and 42 of those were due to commence this year. All have commenced this year and there is a high level tracker in terms of those priorities which should have been shared with the paper and what hasn't been included as an appendix. So I will ensure that that's shared immediately with all board members and as part of the public papers. So overall, the paper outlines some of the work that's been undertaken in support of those actions. I won't go through them all, but would just like to pick out some of the particular highlights. And noting that some of these actions have emerged with some creative and innovative ideas through our staff networks or through different networks across the health board. Some of the highlights and new schemes will have been including the health and wellbeing passport to support staff with health or disability needs, which Louise has been involved in, and that's been received very well, and we'll be evaluating that later this year. Our aspiring board member scheme, which we'll all be aware of. There's been much work undertaken and is noted in the paper around improving accessibility for patients across various services, and also to support improving widening access for people with protected characteristics to employment and training. I think it's also worth to note that our patient experience and involvement team have been awarded Diverse Cymru's Cultural Competence Certificate, and there are further plans to roll that out for other teams across the health board. I'd want to draw particular attention to the board to the Welsh Race Equality Standards update within the paper. Nicola and I attended a meeting with Welsh Government colleagues not so long ago to have some feedback on our outcomes from the RES standards. I can confirm that our outcomes are very similar to other NHS organisations across Wales. There's nothing particularly outlying there, and we'll be working through our race advisory group and our Voices network to work on the areas for improvement within that. And some key priorities moving on for the next 12 months will be building on the next steps with the RES, including our requirement to be 100% compliant with anti-racist training by the end of this calendar year for all staff. We've only just been able to pull the learning through to ESR, so there'll be a big push on that moving forward. Supporting the LGBTQ+ action plan, and you'll see in the paper there's been some really positive progress through events most recently within the health board. Evaluating schemes which are already underway, and especially evaluating our reverse mentorship scheme, which people around the table will have been involved in. There's also a note in the paper in terms of our plans in terms of equality impact assessments and how to improve them. I'm very much focusing on patient experience and staff experience through our priorities over the next 12 months and beyond. So just want to obviously accept any questions, but request that board note the update and approve the actions, but also improve the public facing document, which is attached in an appendix, which you will see highlights the key points, but is designed to be a publicly accessible document to engage our staff and our population in our update and the next steps. Thank you.
Thank you, Sarah. Thank you very much for that. Lots of hard work has gone into this and the improvements that have been made. Are there any questions, Louise?
Yeah, thank you, Sarah, and yeah, acknowledge that there's loads of work being done in the last year. It was great. I'm just really pleased that we've invested in this team and expanding it, and I think it just goes to show if you put the right people in the right place at the right time, that you can get lots done, and I think they've proved that as they've gone along. So just like to say thank you, because we've been asking for this for a long time, to have a bigger team to be able to deliver this agenda.
I think that's thanks to the people who stepped forward and come to work with us, particularly David Chaffee, who came to us initially on secondment through a desire to support this work, and especially the accessible work for patients and the visibility work, which has been really positively received. And you know, thank you for that, Louise.
Thank you, Louise. Ellen?
That's, just wanted a huge amount of work. You know, lots of very innovative projects going forward. Just wonder, are there any areas where you think there's a particular challenge of things perhaps that haven't started, if there's any reason for that, or just it's work in progress?
I think there are a few areas of opportunities, shall we say, for us to improve our approach. So part of the improvements which we'll be focusing on is building on the work we've already done to give some structure and governance around our staff networks. So there's more that we can do there in terms of bringing the chairs of the networks together, understanding the relationships and the governance arrangements around the networks, the advisory groups, and how we bring that forward. It's already in train. I think there's, while I mentioned earlier that this report has been written with input from across the organisation, there's definitely more work going on or more challenges that we may or may not be aware of. So the plan is for the next 12 months and to prepare for our actions and update this time next year is to bring key multidisciplinary professionals together from all areas of the organisation. So we have a rounded view, and we can assure ourselves that we're capturing a wider picture than we already are.
Thank you for your team for the model.
Paul.
It's an incredibly important area of activity, and thank you for the report and the information. Charitable funds may be an area for you to think about in terms of potential funding for opportunities. We've got, particularly now, the staff networks appear to be embedded. So I think there's opportunities for conversations with all of them as a group about whether or not we can assist with anything.
No, it's really well done. Thank you, Paul.
Really.
Thank you. Thank you, Sarah. So are we happy to approve the public document and the update against delivery? Yeah. Okay, thank you. So we move on to 5.5 complex and long-term care independent provider fee uplifts. Leanne, thank you.
Thank you, Chair. And just for clarity, it is actually related to just on the agenda. Instead of 24-25, it's actually sort of fee uplifts for 25-26. The paper does outline that, so I'm not sort of so bothered. The board will be aware that we have tried to make consistent our approach in terms of agreement of fee uplifts for our CHC and independent provider on an annual basis. I brought a paper similar to this last year for agreement. A few things I think just to note in summary, noting that the board will have read the paper. A couple of key inflationary sort of issues that I think is driving the uplift, the increase in national insurance contributions in particular, and the real living wage, both of which is driving probably a slightly higher than anticipated inflationary factor for us. The paper outlines a consistent approach across both CHC that sits under primary and community division and mental health, again trying to make consistent our approach in dealing with our providers and care homes more locally. The financial impact of this in total is pretty much in line with what's been included in the annual plan, bar 155k, but I'm confident through management of growth and the savings plans that we have in place in both mental health and LD and complex care, that will be within tolerance for us and that we would be able to manage within that inflationary uplift in particular. So in summary, the board is asked to support the increase in fee uplifts on an interim rate of 5.5% for care homes in Gwent. That will be dependent on the NHSP award announcement, sort of to finalise that, and then an uplift of 6.9% for dom care and placements for individuals, and NCCU published rates for placements will follow as determined by the NCCU framework. So would welcome board support for signing off the uplift paper, please.
Thank you, Leanne. Any questions? Can I ask about the real living wage? Can we insist that it's passed on?
We ask our providers to sign and submit back to us that they have adopted that, and that forms part of our contractual management of those providers. That approach is taken in both CHC and mental health.
Fine, lovely, thank you.
Yeah. I think this is a good report on the principles of the uplift. And I think this will bring into more focus the discussion we had in the Regional Partnership Board, of course, about that list of third sector organisations.
Yeah.
Because I think we agreed that we would look at that.
Yes.
I think that report would easily read across to
Yes.
that. So,
Yeah, that's helpful. You would?
Yeah, and usually against what I normally bring up in this place, but do we think it's enough to, we're always being told there's a crisis in getting staff into these areas. The increase that we're proposing, always going to be, is that going to be enough, do we think, to close that gap?
I think.
Or we just, continuing along, scraping what we can.
There's a lot of work for us to do here and in terms of the quantum we spend across all of our public sector services and spending the money in the right place for maximum outcome for our population and our citizens. We've got a local authority workshop next week, haven't we, sort of on an exec basis about how we share data more easily and we track the outcomes of investment. And we invest in the right things so that we are, a good example of that will be obviously our pathways of care delays results in patients staying in hospital unnecessarily. So do I think it's enough? Probably not, but I think it's a reasonable starting place, not starting place for us. I think it's a reasonable base for us to then have those conversations with our local authority partners and third sector as well, actually. Via sort of the RPB around actually how we invest, as I've said, I think in a more intelligent value for money based ways.
Yeah, it almost feels as if we're doing maybe what we can and almost we have to do, but that's not going to fix the underlying issue.
No, I think resilience and sustainability in some of the care home sectors and on care provision, I think is really, really key for us. I think what we've not necessarily got is a line of sight around what that looks like, whether it's improving on an evidence-based or data-based way. So I do think is one of the key things, certainly for me in the local authority, sort of that catch up with the local authorities next week in particular, is that what that our data looks like across the system. So we're doing appropriate, I think, demand and capacity work on a needs basis, because I don't think that is currently how we operate.
Yeah. And the RPB itself does the market stability report, so these two can be read together so we can get a better analysis. Okay, thank you. We happy with this? Yeah. Thank you. Amendments to standing orders 5.6. Thank you.
Thank you. So this paper, I'll assume, has been read. There have been recent amendments to our constitutional membership and procedures regulations, and we've therefore been required to amend our standing orders. Those amendments have been made and published on our website, and a summary of those changes are attached in the paper, so the board is asked to endorse those changes.
Yes, that's a good question, Ronnie. In terms of the associate members of the board,
yeah,
in the original makeup of health boards, one of the associate members were nominated Director of Social Services. Is that still in there, or is that?
It is, and we are having discussions about that.
Oh, it's just not in the paper, that's all. It just says associate member. It used to say associate membership including a Director of Social Services.
Yes, no, it is. Yeah. Director of Social Services, and then the chair of the stakeholder reference group, chair. Yeah, it is still in there. It is, yes.
Right, thank you.
Thank you.
Peter?
In terms of the reference to officer members, Ronnie, is there an opportunity to change the word therapies to allied health professionals? It's an outdated term, really.
Yeah, so that is in legislation. Yeah, I wouldn't be able to change.
Okay. Well, try.
I don't know. I'm sorry about that. You'll have to tell the
next round.
Up there.
That's right.
Next round.
We agree that we adopt these. Thank you.
Thank you.
Right, 6.2, the Audit Wales report.
Yeah, so again, I assume the paper is read.
Yeah.
This paper, for completeness, brings to the board Audit Wales's annual audit report for 2024, which summarises the outputs of their audit work in the year, and also presents the structured assessment report for the health board, both of which have been through Audit Risk Insurance Committee in February. The structured assessment report is positive on the whole. The key findings outline that the Health Board and committee governance arrangements are stable and generally effective. However, given its financial and performance challenges, the development of a new long-term strategy and delivery of the 3-year route map are crucial to enabling the organisation's transform services to meet current and future demand. The report provides 9 recommendations, all of which have been accepted, with management responses presented to the Audit Risk and Assurance Committee, and they will be monitored in terms of delivery.
Thank you. Do you want to add anything?
No, nothing to what you just said. You all went through committee, whatever that was. It seems like months ago, but it's probably only a couple of weeks ago.
Any comments?
It can be.
Yeah.
Things to do.
Things to do, but actually I think that's a helpful and reasonable report of the organisation, so I'm quite pleased about that. Okay, thank you. The performance reporting, Hannah, integrated performance report.
Thanks, Chair. And there's a couple of sub-items to this, so I'll keep it brief in the interest of time. So again, assuming people have read the detail, just want to draw out a few key points. You'll see from the report and some of the, in respect to some of the key progress, the promised improvements and anticipated improvements around mental health performance have been not only realised but sustained. So really positive work by Leanne's team in terms of delivering on those commitments, as we know, through a combination of both process, service redesign opportunities. Similarly, we've sustained performance in CAMHS. We're seeing good improvements now in the ND space. So not resting on laurels, so switching to psychology access, and we had a good update from teams at the recent Internal Ministerial Priorities Board on that. Just drawing out as well, pathway of care delays in the space of urgent and emergency care. Over, when you look at a trend, we are on an improvement trend on that. I think, I'm looking at Jenny here, March census will confirm that improvement continues, and we're back down to what we saw in January. We had a little uptick in February. So really positive work there with working with partners and the benefits. We could sort of assume from the 50-day challenge work and linked with all that focus through the 6 goals work. We do have to acknowledge, though, notwithstanding all the work, we've still got some challenges in delivering and then sustaining improvements on some of the other escalation metrics around ambulance handovers, 12-hour waits and wait to be seen. But we can see, following a very difficult winter, some green shoots there, and you'll have seen in the plan some of the focused efforts on how we bring some of those improvements with a real intent to get out of escalation, not out of de-escalation. In the cancer space, so whilst we're not delivering the single cancer pathway to where we'd the trajectory of 67%, really good work and improvements made. January at 63.2%, and we are on a 10th fate, but intel that February is when the position closes in March, we'll see further improvements. So there's been a real focus again in Leanne's team on them taking that tumour site approach, but getting the improvements and sustaining them. There's been a small uptick in terms of the backlog in cancer on the 62 and 104 days, but understanding is still within range of what's sort of manageable, and not expected that that's a new trend of it worsening. And again, we had an update on that in our internal scrutiny group this week. Planned care, as we've touched on throughout, a real national focus. If you think in terms of patients waiting over 104 weeks, in June we had just under 4,500 patients waiting over 2 years. In February, it was just under 1,700 end of February. Whilst we had, so great progress made towards the ambition of 0 at the end of March, we think we're in a position, as updates coming through all the time, even as recent as this morning on some of the non-cataract, but about 350. Hard to give a number when it's changing all the time. Patients who notwithstanding all of the efforts and scrutiny and plans in place that will be waiting by the end of the year, but that number is subject to changes as plans and validation lands before Monday. I think I just want to note again, similarly, progress in diagnostics. We should be eliminated AP rates for endoscopy and radiology we'll have done by the end of the year, which is a huge achievement, with just some challenges in some very particular specialties in neurophysiology and some nuclear medicine. So appreciate I've really rushed through that. I wasn't going to draw out any of the quality areas because Jenny will present in the quality report and ditto Rob the finance. But Sarah, did you want to draw out any of the workforce metrics?
Thanks, Anna. Just to really pick up on some areas maybe which haven't gone so well within this report. We did see a spike in terms of sickness absence over the December and period, and higher than normally expected during those winter months. Key focus was with healthcare support workers, estates and ancillary staff, and nursing and midwifery. We are beginning to see those come back down to more expected levels of absence. And that did have an impact on a slight increase in variable pay over this period as well. And it was work considering sickness absence. And within that reduction, I am pleased to say that the main reduction has been in long-term sickness absence as well over recent months. So supporting our long-term staff be able to return to work is key. Just want to pick up some progress as well in terms of job planning. James, I think we're beginning to see more progress with 4% increase month on month. Whilst it's it's still a long way to go, but we are beginning to see some green shoots. And our time to hire has significantly reduced in terms of bringing new people on board, and has continued to reduce over recent months as well.
Thank you. On performance, can we just deal with this section? Performance. Any questions or comments? Can I ask about the performance on stroke admissions directly to a stroke ward? Has dropped quite a lot, to 9%. So what are we doing to improve the situation?
I don't know, yeah.
Comment. Yeah, thanks. So we've got this. That's one of the key planks of our stroke improvement plan, is the front door access, of course, because that's our problem area. We've done some work over the course of this year around ring fencing the capacity on the hyperacute stroke unit. We've done that because we saw the benefits that Cardiff achieved by doing that. They had a significantly improved performance. That's only part of the story though. And it's all well and good having a ring fence capacity, but we also need to have really clear escalation and surge options for stroke, particularly when we experience those surges in demand, which we've experienced a lot over the course of the winter. Since we ring fenced our hyperacute stroke capacity at the Grange back in the summer, we had some months where we lifted our performance right up to 30, touching 40%, and it gone down. So what we've seen is a very variable picture in performance. And what we know is, whilst we can ring fence a stroke, if we can't maintain the flow at the front end and we don't have clear escalation options, then that so easily drops back down. And then we're dropping down at a level of about 20%. And then the level that you quoted there was very low, and 14% or whatever. So I think the work that we now want to take forward is combining that, holding the ring fencing, but looking at how we escalate and we surge when we get that. I think those two things together will enable us to get back up to 30, 40%, but hold it and protect it and keep it going. It is really challenging. Stroke is one of those urgent care pathways that's very variable, and when the rest of the urgent care system is struggling, stroke will struggle as well, so it doesn't stand alone in that sense. So yeah, quite a significant amount of work that's going on there. And it's not just the access, it's really important that when a patient comes through the front door, We're looking after them from the moment, not just when they get up to the hyperacute stroke unit. So we're very mindful of the fact that for some patients that there is a delay. But what we make sure happens is even if they're in ED waiting to go upstairs, that we start thrombolysis, we start thrombectomy, we do the swallow assessment. We don't delay giving them the life-saving treatment they need. So that's very much our focus really, is on the kind of quality outcomes as well, not just the time pathway. So huge amount of work happening at the moment, that part of the stroke pathway.
Thank you, Peter.
I think just to point out, we mentioned some of the peaks in demand, and
Yeah.
right, yeah, I think 1 week we had 38 strokes where we normally have about 20.
Yeah.
And you know, just some of those, you know,
Yeah.
exceptional peaks to try and then manage that in
Quite.
is quite a key issue.
Oh, I know it's terribly variable, and of course we've had the come town.
Yeah, so we try to understand the
as well.
impact of that with once, which we haven't
Yeah.
got that. Yeah, okay, that'd be helpful as well.
Because I know we've put such a lot of effort and time into improving it then.
Just one thing to add, sorry, was thrombectomy. At the moment we had a poor admission, we did have a thrombectomy rate that was just around 10% or just over, which is what the aim is to get to 10-12%, which again would be interesting to see if it was a development and how we try to sustain that. And that is one of the investments that is in the JCC plan, is that getting the cardiac service established as well on a 24/7 basis, albeit we do benefit by being close proximity to Bristol, but really good to see them come up. Sorry, yeah,
Yeah.
It's just to add, we had a meeting yesterday around exactly that issue, that when we go into surge and have these peaks of demand that come in, how we respond to that in a more systematic way, and we're not leaving it to in an unplanned way. So I've asked the team to map through the pathway, what our triggers and thresholds are, and then our response, so that we don't get into a position where the performance dips off and patients get to the place as quickly as they possibly can. Noting that particularly for stroke, there is a whole pathway piece for us to do that spans out into CNRS as well. So as I said, just as a follow-up and assurance for board around that more systematic approach to how we're managing sort of risk and flow.
Thank you. Any further questions on this section? I think it'd be lovely in the future, and I know this is not our issue to fix, but I think we can do something. See, a lot of this is about hospitals. So, you know, how do we measure improvements in the community? And I think I'd like to see that built in for the future. Penny?
Yeah, I was just going to talk about the stroke as well, which, you know, is quite concerning, but, you know, understandable with the peaks. Perhaps we could have more in there about, you know, the concerns around that, which, so that we understand the figures. But I just wanted to say to Leanne and their team, I just wanted to highlight, you know, their progression in mental health figures and stats and in the division. And I really think they've done a fantastic job. I mean, I've never seen stats go as fast as that. As high as that ever. So well done all, and I look forward to hearing how it was done. Thank you.
Thank you. No, that's really.
Thank you for the recognition, Penny. I'll make sure that's conveyed to the teams. They've been working incredibly hard on it, so I know that will mean a lot. Thank you.
Thank you. Any more questions on this section? Quality?
Chair. So this is an interim report. It's not the full quarter. This is January and February's data. I'll take the wider slide deck as read. Just a few areas to highlight. I'll start with the good. And as you know, this is our reporting under the duty of quality and the duty of candour. So with mortality, our RAMI remains consistently lower than the Welsh peer group for the majority of and that's remained the case for the majority of 2024 and into 25. As you know, we've been doing a lot of work. You've heard from the PALS team earlier on patient engagement and patient experience. Our Civica satisfaction rate remains over the 85% benchmark and was 90% satisfaction for January. There's always a piece for me in how do we understand the 10% who are dissatisfied and how do we bring that experience forward as well, which I know we do in stories, but we do in terms of our learning and improvement methodology. We've also got the text option in ED, which has gone live, and there'll be a text option for maternity in terms of a new Civica survey as well, which is mandatory. There is an issue for us to consider because Welsh Government are considering a number of mandatory surveys which will need to be sent out by text, but of course that doesn't always follow with funding to go along with that. We've improved our position on overdue nationally reportable incidents, so we only were compliant in around 30% of cases last year. We've got that down to we're compliant in over 70% of cases. So that's been a huge improvement, and lots of work with the divisions in terms of timeliness of reporting. We do have some very aged cases in our nationally reportable incidents over 12 months. They tend to be in another process, either safeguarding police process or will be more complex in nature in terms of understanding. We've had no new never events still, so that's a brilliant position to be in, and fantastic work with our theatres team in terms of improvement. And despite a little bit of a dip, 1 month, we've maintained our RIDDOR performance at a high level, which is great in terms of that external reporting. We also have the launch of the Safe Care Collaborative, which will be done in May. So the theme this year, this is a national programme of work on improvement. The 3 themes are leadership for safety and improvement, so really trying to equip our senior leaders with the right skills and competencies in QI, deterioration, which very much goes to a theme that comes through our nationally reportable incidents on patients who, unfortunately, we don't pick up their deterioration during their care within the health board. That's continued to be a theme for us, but some really great opportunities to learn and improve. And deconditioning, which is related to patients who are medically fit but shouldn't be in hospital, and ways in which, right from the point at which they enter our system, or even when they're in the community, how we stop that deconditioning, so avoid muscle wasting and loss, that paternalistic approach of care to make sure they maintain their independence as much as possible. And just building on our work on collaboratives. So we've done a lot of work, as you know, around engaging people in the community. We have dementia cafes, we have our collaboratives. We've done a lot of collaborative work around bereavement. We are going to do a sepsis collaborative this year with patients and their families who've experienced a person with sepsis. So that's going to be really important in terms of our learning. Unfortunately, areas that continue, most of these have continued to be an area of focus and concern. So our infection rates, particularly for C. difficile, as you know, have risen over the last 12 months. It's a picture seen across Wales. It's very complex. We have community prevalence. We have issues clearly with patients with complex comorbidities, but there is things for us around our polypharmacy. Obviously our antimicrobial prescribing, so overprescribing of antibiotics or the wrong antibiotic, and also that basic good IPC practice every day. And interestingly, when we introduced additional measures over the winter, we did see a downtick in our infections. We're not out with the national picture, but clearly we don't want to be in a position of breaching our Welsh Government reduction targets, which we will have done, unfortunately, for this year. But much work in place, lots of work on the basics of IPC. And I think we're going to do a visit to Leeds Royal Infirmary, who've halved their C. diff rate by focusing on human factors effectively. So the human element of that. We continue to see variation in the number of inpatient falls, and I'm sure Peter may want to comment on that. And we are putting in some focused work on improvement. And the other thing to say is that we've seen a real uptick in our level 1, level 2 safeguarding training. We've had an issue where level 3 training, which is for clinicians in the main, has been an issue. We've worked with Sarah's team to put that onto ESR, which means we'll now be able to monitor that. And we've launched our new training, which is more focused on divisions and what clinicians need. And we're now oversubscribed. In fact, we don't have any spaces left until October. So we're outstripping our capacity. And the final thing to say is really that we continue to not be where we want to be on our PTR closures, but we have done significantly well. As of this week, Nicola, we should have no over 12 months. I think there will be 2 with you to sign off. So we will have 0 over 12 months. We are in single figures over 9 months. and our in-month compliance is increasing. So as you know, because the focus on the backlog, it's affected our in-month compliance. So we're also getting less upheld cases by the Ombudsman, which means, to me, that means our quality is improving, our timeliness is improving. So we are at around 76% for early resolution. So that trying to put things into that informal space, but satisfying people with their concerns. And we teeter about 50 to 60%, to just about 10% shy of the national benchmark on 30-day closures. Happy to take any questions.
Thank you, Jenny. Any questions for Jenny? Helen?
Thanks, Jenny. Obviously, I'd like to acknowledge a lot of progress being made in a huge number of areas. Just coming back to a minor point, what we've raised this morning with the PALS is there are lots of complaints that are related to communication. And I note you put in here, we've introduced communication standards throughout the health board. I just wondered how you go about embedding that when communication is everybody's responsibility.
It's communication standards for early resolution and PTR.
Oh, right. Okay.
Because often what happens is that it's the communication with people at that early stage that then results in formal processes. So we're trying to encourage that early communication with families and be clear of expectations of, there's nothing more frustrating when Nicola and I receive a complaint that perhaps it's 12 months old, there's been no communication with the family. So we've put into place standards and we've worked that through with our operational colleagues in terms of that ongoing communication, but trying to ensure that we deal with as much as we can in that verbal initial space.
That's helpful clarification. Thank you.
Paul?
Really interestingly, I can't see the page number because it's too dark at the bottom, but it's got patient advice and liaison service. The communication issues with 2,535. What's the issue there then? Because that was raised about communication, is it clinicians obviously talking to patients? Can we do anything to improve that?
I think it's it's very difficult when you are busy on a ward or busy on a unit and you're trying to manage patients who are quite unwell, you're trying to manage the unit and you're trying to manage that communications with families. And I think that's the beauty of PALS, where they can come in and help with some of that. Those 9,000 contacts would have been, 9,000 contacts with staff on the ward who are trying to do multiple tasks. So, much of this is about communication and understanding. And it's trying to find those moments where we can support families who are perhaps, not feeling that they understand the journey for their loved one or that they don't understand themselves, and trying to make sure that we can intervene early and have those conversations, because it does, every organisation I've worked for, it's a common thing, but if we continue to reinforce that messaging around, we can de-escalate much of this if we work with people.
Just wonder about training for clinicians as well then.
We do stage and time training,
right,
which is a communication training, so that's available to all staff.
Okay.
Okay.
Thanks, Anne. So the report includes the month 10 position, which is a year to date to the 31st of January 25, sorry. Revenue position for the year to date is a £7.2 million deficit with a forecast of a £7.3 million deficit. I'll come back to that in a moment. Capital spend at the end of month 10 was 44 million against a £67 million plan, and again, forecast of balance. Our public sector payment policy performance, where we have to pay suppliers within 30 days, is at 97%, which is in excess of the 95% target. Our cash holding was 6.2 million, which is slightly over the £6 million best practice level we've been set as a health board. Our underlying position is reported as at month 10 at £14.5 million. You'll note from this morning the annual plan update, which is more up to date rather than the 31st of January at 27 million. Just to note that's why there's a difference. It's a timing difference. In terms of the forecast, our control total set by Welsh Government following the 4.5 million funding we had is now 7.3 million, and we are expecting to deliver that. Since publishing the report, we have run month 11, and I can confirm that the forecast is being held at 7.3, and we have a high level of confidence of delivering that position. In terms of savings, the plan identified a £40.5 million level of delivery. We are forecasting £45.4 million, so £5 million more than plan. As at month 10, 35.2 was achieved at year to date, and we are expecting again at month 10 £44.1 million and 97% level of green savings, green being confident of delivery. So our forecast of £45.4 million savings also includes £32 million worth of recurrent savings, which supports our underlying position. Pay in month to January did increase, and that's due significantly to payroll back pay, but we did have some increase in our variable pay. We also did, however, increase on our full-time equivalent substantive staff by 91. So that's again a positive move in when we're strategy to recruit as much as possible to avoid variable pay where we can. In terms of non-paid bill increase, most notably is a £2 million spend forecast change in terms of RTT waiting times funding and a contract for cataracts, which was outsourced and funded through national funding. In terms of other operational areas, so our drug costs continue to be at higher levels than previously expected, but we factored those in from more recent months. CHC continues as a pressure, but has stabilised at just over 500 patients, and our elective activity is continuing aligned to plan. And overall, our pay and non-pay run rates are stable, and hence the confidence in terms of delivering our forecast outturn. We do have risks in terms of the uncertainty around pricing and volumes of prescribed drugs and the finalisation of the JCC Specialised Services cost plan. We do have mitigations to cover some of those, and overall, the position, as I say, to achieve our forecast of 7.3 million deficit is a high level of confidence, and we're online to deliver that. So the board has to note the report.
Thank you, Rob. Are there any questions to Rob? A pretty clear report. Okay, thank you very much for that. 6.4, the strategic report, Nicola.
Yeah, just to keep it brief. So the report updates the two changes we recommended last meeting around reducing the workplace risk and adding the decarbonisation. Kind of sets out those areas that are outside our appetite, with clarity, with financial sustainability being the highest score, which we can consider as we look forward as we go into 25-26. And we picked up at the last meeting as well the issue around workforce risk, particularly around the recent announcement for consultation with Cardiff University. So we've just noted in there that it will be picked up as part of the kind of corporate risk and assurance process once we understand a little bit more about the impact and some of the further discussions going on around that. But we have noted that came up last week.
Yeah.
So it's just really to be content with the risk register remaining as is with the changes we agreed last time.
Thank you. Any questions or comments? No. We've reached the end of the non-confidential section of the board. We agree with the consent agenda. I'll just ask again, is there anything to come forward from that agenda? Are you content to leave that? Thank you. The date of the next meeting will be the 23rd of May. We will continue this meeting in committee at 2 o'clock. Yeah, 2 o'clock, half an hour. Thank you very much indeed for the level of questioning today and your comment. Thank you.